there's a separation of the annulus from the end plate and the fragment was down migrated. It usually is that way. Whenever there's a migrated fragment, please search for the rent at the annular bone apoptosis interface. And you will always find it over there. So this is exactly what we were talking about, and this is exactly what we are seeing right now. But you know, I very beautifully removed the most of the fragment. I think your patient should be quite comfortable, Shambhav. Yeah, do a little bit of annuloplasty, and I think you can call it a day. Shambhav, we'll be cutting off from you because you're running a little late, and we'll be continuing with our lectures. I thank the panelists.
Thanks, Dr. Shambhav, for very nice, decent, skillful surgery and showing us how to get out of it. Thank you very much. Let's give him a big hand. Get the claps.
Shambhav, and I really like your approach. Better be safe than be sorry. So it is a wonderful demonstration.
May I request Dr. Pang Bang Ho, Dr. Daniel Hudson, and Dr. Satyan Mehta to remain on top as moderators for the next session. Dr. Dan Hansen and Dr. Pang Bang Ho, can you please take the sofa? We have Dr. Sean Winter, his second talk for the day. Actually, it is a rollover talk from yesterday, which he's now giving. And then we will continue with our regular list.
Thank you very much for the opportunity. So today I'm going to be reflecting my first 50 transforaminal cases, and the old saying of if you don't have complications, you are not operating or you're not following up. Now this is a photo after the first UBE case, after the tutorship with Prof. Eigen. And you can see everyone smiling, but when you 50 cases down the line, you need to reflect, and you need to make sure that you are progressing in your skill set. So my question that I asked myself was, where did I go wrong? And this is my outcome timeline, and you can see clearly so the gray bars are reoperations, the orange bars are complications, and the blue bars are good outcomes. So I started off with a fantastic run of 2 reoperations of my first 2 cases.
That's honest and that's nice.
And I've come up here today to be completely honest, because I think we need to be honest when we do the surgery. And the first case, Dr. Malcolm was in my ear, and we were doing a WhatsApp call with, you know, and it was a fantastic experience to have it like that. But at the same time, you know, you need to build your confidence without getting all these complications. And the reason why I asked, chose my first 50 cases is because everyone says it takes you 50 cases to become proficient with transforaminal endoscopy, or with any endoscopic surgery for that matter. So I broke it down to a timeline analysis, and my first 10 cases, my first case, I did a TLIF 7 days afterwards because the patient was still in severe pain. Initially, she was actually doing fantastically, day 1, day 2, and I think that it was partly because of the steroids. And then when I did the TLIF, I found that there was a incomplete discectomy. There was fragments under the nerve root. And having done the TLIF, it was actually so valuable because I was able to see what I had done during the transforaminal. I thought I was going to find this massive hole in the disc. And both me and my colleague, Dr. Extian, we were surprised at the small footprint that you leave behind. So my second case, We performed a TLIF 2 months down the line, and she had this ongoing radiculitis, and possibly if I'd been more experienced, I would have possibly reassured the patient a little bit longer, and she would have been fine without having to progress onto a TLIF. But again, the open surgery and seeing what you've done provided so much valuable insight into my practice. Because at that point I saw that there was some adhesions between the disc and the nerve root, and that was what was causing her pain. So, at the point where I'm at now, I probably would have gone back and done an endoscopic revision, and I would have seen these adhesions, and I would have saved her from having a fusion. My third case, which was on the fifth patient, only required a TLIF at 12 months, a year down the line. And they had a very good outcome. And 10 months later, they had discogenic pain, failed all conservative managements. And the job that they were doing, they required a definitive management. So we decided to go on to a TLIF. And then case 7, it was also at 2 months. Patient had ongoing poor response and had discogenic back pain. So we decided, and it's always important to take your patient into account as well. What job they do, what are the requirements, what are the expectations, and a definitive management at this point was what the patient required. And then my one complication in the first 10 cases, there was radiculitis, but it cleared at 6 months, at 3 months follow-up. So 5 out of my first 10 cases, which was a 50-50 start. Not the greatest ways of starting your career as a endoscopic surgeon. So then cases 11 to 20, it was my case 14. I had to perform a TLIF at 3 months. Patient had ongoing pain, and then there was a very good outcome. But you can see that there's 2-level disc involvement here, and I suspect that there was partly it wasn't necessarily just the transforaminal case at 4-5, but it was possibly a discogenic pain at 5S1 as well. Then case 16, I had to perform a TLIF at 12 months, and she really did well for the first 11 months, and then she had the sudden drop off. We performed exhausted all the conservative management, but she's a rheumatoid patient, and I think that was a good choice in the end. Then case 19, very interesting. Patient had this foraminal disc herniation, and it was my first case where I got that big fish, the one that you're always hoping for. And the patient was doing fantastically. And 3 months later, he picked up something, and he had this almost replica disc herniation. And at that point, I decided to do a MIS discectomy, fall back to something that you're familiar with. You can assure the patient that you've done a complete decompression, and he's doing well. Now, the one complication was for my 17th case, which was very interesting. It was an extraforaminal disc, and it was, again, one of those cases where the time for surgery was quick, it was efficient. I docked right onto the fragment, and I got the discectomy out very quickly. And then, 10 days later, he started presenting with pyrexia, back pain, and we said something's going on here. Has he got a discitis? And for this case, we basically docked in this region here. So extraforaminal didn't come near the facets. And when we did the CT scan and the CRPs, he had a facet osteitis. So he required antibiotics for 6 weeks, and he resolved, and he's doing well at this point. So my second 10 cases, I'm down to 40%. So I'm doing a little bit better at this stage. Then between 20 and 30 cases, my case 27, the patient had radiculitis, but also associated weakness. And I'm going to come back to this case a little bit later when I'm discussing some of the other issues. And case 29, also radiculitis, which improved in 6 weeks. Then case 30 to 40, again, I had 2 radiculitises. So my second stint started getting much better. Now, when I started analyzing and asking the tough question as to what was going on, why was I getting complications, and what was influencing it, as far as my technique was concerned, not much has changed except that my time in theatre, or the time that I was in the foramen, had reduced dramatically. I've gone from 87 minutes here to 41 minutes at the end of the 50 cases. And I think it's a large degree where you are confident that you've done enough. You're not fiddling, and I always call it the fiddle factor. So that was very important for me. Now, the other large component of my improved success rate was the pathology I was selecting. I was no longer selecting cases that were either very technical or that was not really going to give me a good outcome. And this is a TV spine patient that presented with this massive abscess. And this is the MRI 24 hours after decompression. And that is a lovely decompression with a very small footprint. As for the patient selection, the one thing that really stood out for me, we've got massively obese patients, we've got malnutrition patients, but the one thing that really stood out for me was the depression score that we take. We do it as a routine for all our patients, and we use a modified Zoom score. And I found that all the patients that were rated above 30 on the score were more likely to have a reoperation or a bad outcome. So this is not the psychiatric patient running. That's me running away from the patient when I see a increased depression or anxiety score. So the other interesting part of these patients that's got the increased depression score or anxiety score is that the need for anesthesia is much higher. They tend to use a lot more drugs in order to have the same level of conscious sedation. Now, patient selection, anesthetic selection. Now, this is the case that I was going to come back to, is that at the point where I was getting comfortable, I was allowing other anesthetists to start doping for my patients. But they didn't have that fine tune or that understanding of what was my requirements. And they were making patients too deep during sedation at critical points of the surgery, especially when you are at the nerve root, and that constant communication with patients where they are asking patients, are you having pain down the leg? And I had to almost revert back to 1 or 2 anesthetists who are comfortable and understand the fact that they need to communicate with the patient at all times, because this is live neuromonitoring that you've got. So it doesn't help that they are, completely pain-free, but they can't communicate back to you. Now, in summary, the advice that I can give you with my journey is that you need to attend a course like this. You need to attend a cadaver workshop. You need to have good training. Then you need to find yourself a mentor. And that mentor walks a journey with you. And you need to be able to fall back and ask that mentor difficult questions. The learning curve, that is a natural thing. And it's always going to be, you're going to have complications. But one of the other things that I've changed or that I brought into my practice is that I introduced a coach. So just like any sportsman that is performing at the top level, get yourself a coach. Have somebody that comes into your theater and looks at you critically. Let them start saying to you, why are you scratching on a nerve? Or why are you setting up your theater? Ask the difficult questions, because that's going to make you think about what you're doing, but it's going to improve your outcomes as well. Then what I've done here today, go and reflect on your cases. Don't just move forward. Look back and reflect on the cases that you've done. Learn from your mistakes. The patient and the team is of utmost importance. Selecting the right patient, and then obviously your team that you've got needs to be consistent. They need to be familiar with your techniques, because it doesn't help you've done 40, 50, 60, 100 cases and suddenly you've got a new scrub tech and they're running around. It breaks your rhythm of your surgery. So thank you very much for
Hey, thanks, Sean. I'd have to agree with you. I had a coach. I ended up in America. I found somebody who was willing to be the guy that I talked to, and I couldn't emphasize more than enough that finding somebody sometimes can be the hardest thing that you're looking for, because you want somebody who's more experienced than you and you don't know anything. So it could almost be anybody, but it's somebody that's got gray hairs on their head and been around a while, you know.
You want somebody that's not afraid to actually say it to your face, because unfortunately, you know, at some point you get this ego and everyone's afraid to comment or to give you criticism. And when you've got the person with the gray hair that is able to say to you, Sean, I think, you know, do this, that, you don't take offense, and it's lovely. It's a very nice way. Any questions? Good.
Thank you. Thank you for this honest presentation, I would say. We welcome Dr. Pang Ong Wu from Singapore. He's been one of the pioneers in endoscopic surgeries in spine, and he'll be giving his talk on revision cases in biportal endoscopic spine decompressions.
Thank you, everyone. I must be I'm very inspired by the reflection of the previous speaker. Thank you, Prof. Malcolm, Prof. Anand, and Prof. Sameh for inviting me to this Third World Congress of Spine Endoscopy. Today, my topic is unilateral bipolar endoscopic decompression, UB decompression for adjacent segment degeneration. This is my conflict of interest, some of them relevant to this topic. I practice in Singapore. I typically look after 12% of the Singapore's population. I do a mixed practice in an academic center. 50% of my practice is uniportal and the other half is biportal surgery. Basically, I do 80% of my cases under endoscopy. As we know, open wide laminectomy has caused initial good results. I think 88% of success at 6 weeks to 6 months. And then overall, over time, there's a deterioration and there's a recurrence rate of the same level. As a result, there's an introduction of posterolateral fusion. And they are successful in fusion, and especially in preventing spondylolisthesis progression, but there's a questionable clinical improvement. However, nevertheless, it takes off, and it takes off very rapidly, especially in the realm of interbody fusion. And proponents of implant companies mixed with remunerations in America, especially also with good outcomes and data, really interbody fusion take off. And along with the interbody fusion, it's a highly invasive procedure, and then we evaluate and we realize that complication rates is not low, and there are several studies show that it can be as high as 25%. And one thing we are aware of is adjacent segment degeneration, and as we follow up the patients longer, we find that there are more and more a higher incidence of ASD. So there are some studies shows that a follow-up of 10 years can be up to 31%, which is quite significant. Of course, in general, we quote patients doing consent is about 10%. And in elderly, it can be higher revision rates and infection rates, major complications. So do we do adjacent segment degeneration by actually revision fusion, fusing higher level? Perhaps, how about lateral access fusion? How about going to correct the surgical alignment and going higher to T10 to pelvis? And if that's not enough T4 to pelvis, sometimes we have to think back and say that we can't solve the problems by using the same kind of thinking that we used to create them. So there are some issues of fusion that's addressed by MIS decompression that comes in the late 2000s. They're trying to address the issue that they pick up in the 1990s, which is basically maybe we can do a laminotomy preservation of the posterior tension band, and yet we can achieve sufficient decompression. And for those cases with just spinal stenosis and grade 1 spondylolisthesis, maybe that's enough so that we can prevent adjacent segment degeneration. One of the issues about one of the discussion that is quite common in UBE versus tubular microscopic, the incisions can be quite small. If you add two UBE incisions together, that's tubular incision. That's a common question that was asked by the open surgeon. However, one thing that we have to understand, the key of UBE is not only visualization, it's not only about incision size, not about only collateral damage, it's mobility. You see right here in the tubulars decompression, the tube is down right in the interlaminar space, and it fits snugly in the interlaminar space. As a result, you can't really move. So as a result, we have to, do a bit more laminotomy to create a space that's less snug for the tubular so they can move. And that can create more bony resection. So as a result, the open laminectomy was introduced, and then now tubular tubular resection, and now bipolar. On the other hand, you can see from this video, there's a significant mobility, and you can get around the nerves quite easily from one side to the other with a very little resection of the spinal laminar junction, and you can quickly move from one area to the other as much as we can. And we can use the similar tools that we use in tubular decompression. So right now, we'll get back to ASD. So the key factors of revision in ASD is, again, evaluation. We have to understand what is the previous fusion in the open laminectomy and fusion, whether we should go through the interlaminar approach or a far lateral approach. I think the key is how proximal is the extent of laminectomy. If a full laminectomy, for example, in a patient who have a L3 to S1 fusion, and the L3 is fully laminectomized until there is no little sleeve or caudal laminar left for you to dock your scope as well as your working instrument. You have to be very clear that there will be adhesion and there may be a chance of dural tear. So bilateral, far lateral approach is one issue that you can do to do a lateral recess decompression. But if necessary, we still can go through the interlaminar space, and then we have to follow the key steps, which we go through. First, when we dock on this, we have to dock on the safe landing zone. And of course, you can see that in the revision setting, we will dock on the laminar instead of the interlaminar space, because when we use dilator, dissectors, bluntly, you can actually cause dural tear, as is shown in the next slide, if we are not careful in the revision setting. So in this case, we can subsequently, next step is to do clearing of scar tissue. Scar tissue doesn't only occur in the dural level, epidural level. It can happen in the a lot of, especially open cases, a lot of time in the soft tissue as well. So you can use a shaver at this point of time, or you can use a more liberal use of plasma coagulation. And then when it comes to the laminar exposure for the scar tissue, the epidural space just above the of the dura, I think there are three areas that you can work on. The first area is just at the proximal of the cephalic lamina. The second one is at the facet joint, and then the third place is actually at the pedicle. I think at the third place, when you release through the pedicle and you go really deep down, that's the next step. you did the adhesiolysis, the 3 point as we mentioned, start from the middle, then go to the proximal, and then the distal lamina. The distal lamina ended usually typically at the pedicle. So when you reach the pedicle, you go deep in and dive into the ventral vertebral body of the next segment. So for L45, it will be L5. And then you know where is the deepest part of the spine. You can check that with a fluoroscopy, and then that is double confirm that where you are. And then from then on, you are confident, and then you can do the SAP resection, and then we release the lateral recess. And that in that way, it can be safer. So this just to highlight the proximal, the middle, and the distal area. The distal area, I typically look at the pedicle, and I find that over the pedicle area, they usually have the least adhesion. So just a few couple of cases, I maybe a short of time. So fusion L3 to S1. This case I analyzed, and that the proximal lamina is intact. It will be an easy case, almost like a primary surgery. I have described my technique in this textbook that is by Javier, and then this is how we set it up. There's a two way of doing this UBE or BES. I think the incision is different, and then they use more osteotomy in BES. I typically use UBE for revision, and that's how we do it. I mean, the docking is as such, and then we this is like a primary surgery because the proximal part of the lamina is still intact. So it's very important that you do a CT scan and you evaluate in the L2-3. If the L2 top of the L3 is still intact, then you have a primary UBE surgery. So it's pretty easy. I can use a cutting burr. I'm less cautious about dural tear. Of course, we are always cautious, but not as like, you know, a revision case. So just to highlight, I mean, the typical standard way of doing UBE, I think in UBE in the L2-3, L1-2, as well as L3-4 level, creation of space is important. Sometimes I use the osteotome so that I don't bend my drill. So once you get to the top of the lamina, you can change your diamond burr and subsequently do a release of the flavum. I think this style of video is shown commonly, so I keep going because I'm a little bit late on time. So this is a patient who basically I discharged most of my UBE. Interestingly, one more point in the revision surgery, a lot of time they don't have a lot of bleeding, so you may or may not need a drain. And in this case, it's very fortunate I can actually put the incision back at where it was, so she has no new incision. For her, she has a drain. You can see that there's a drain that I tape it up with. So then this case, this is a 74-year-old man, and then he has a very interesting way of fusion. I mean, that is something that we did in the past with a pedicle screw. As you can see, he has a wire right over the lamina of the caudal lamina that I'm going to do a revision surgery. So I would expect to have dural adhesion. Then I assess him. I think the main component of compression is central region. So I did still choose the interlaminar approach rather than the paraspinal approach. I talk about the far lateral approach, but that is for lateral recess stenosis. If there's key component still central stenosis, then you have to bite the bullet, and then you expect maybe a little bit higher rate of dural tear, but still go for interlaminar approach. And this is how we do it. The left side, and then there's metallosis. I think I spent a bit of time here because this case have a dural tear, but it's not a big one. So in the end, we could have just patched it with gel foam and Tecosil. So I typically use a cutting burr first. I think it's a little bit faster on getting a laminotomy to the proximal junction. Then I switch to the diamond burr to actually go to the top. Just like Haman mentioned yesterday, I tried to do one block resection technique, but a lot of time in the upper level, I think it's a bit harder. And you can see here metallosis with a dural adhesion. So you know you may have a bad day in office if you have bad dural tear. So in this case, this type of time, right, you have to use a sharper, ask for a sharper kerrison because you really need to take out the flavum piecemeal sometimes and carefully, rather than you drag out the flavum with a blunt kerrison and then there you have a huge dural tear. If you use a sharp kerrison, at least you have a smaller dural tear as a result. So you can see the metallosis at the adjacent area, and I realized that there was a dural tear. One key component of this is to actually complete your decompression, and then you patch it with a Tecosil. Fortunately for the patient, there was no leakage. I just wanted to show you this. I kept the patient rest in bed for a day so that I'm confident that he has no problem. Yeah, he walks before the surgery this way, and he walks after that the same way. He's quite cool with his urinary bag, and immediately after I get him up from rest in bed. So he's pretty good, and he was discharged. He's comfortable. So in the end, I think if we can try to not put our head out and get shot, so we have to plan. A periscope in the past, I think, is useful. We have to make the decision on correct target. We have to use the correct weapon. Sometimes you can use uniportal and biportal. If you have all those things in your arm toolbox, then you can choose the correct scope to do the correct surgery. And then proper docking of the scope, you have to plan that in the revision surgery. And then, of course, the advantage of clear visualization in both uni and biportal is there. You can use the water pressure, and it's very helpful to help you retract the adhesion tissue away so that you can do your biportal surgery. And I think there's a lot of benefit in a separate portal, and then it minimizes collateral damage. Just a little advertisement. I'm going to be a guest editor in this medicinal journal, which is PubMed and Impact Factor 2.9. I think we'll be hopefully a lot of you are endoscopic expert. Maybe you can consider submission to there. Thank you very much. Any questions? Oh, Dr. Hayati, yes. He's the expert of, I learned my scope from him too, yeah.
Thank you very much.
Yeah.
For your perfect presentation, but I have a question. You know, there are some reasons for adjacent segment pathology.
Yes.
One, maybe we can say that the poor alignment, or
Yes.
and the other thing is poor surgical technique.
Mm.
The poor surgical technique includes that if you cannot preserve the posterior capsuloligamentous complex with the bad biomechanical alignment, you can face with the adjacent segment pathology.
Yes.
If the patient has some comorbidities or job-related issues, the time may be shorter than normal. So UDIN surgery, very nice. The compression is perfect, but how can preserve the posterior capsuloligamentous complex? Because I think you changed the portals, right?
Mm.
Yeah. So we in UBE, we trying to use the multifidus triangle to protect the posterior muscle growth.
Yeah.
But you change your portal.
Oh, I just used the medial pedicle line.
Okay, okay. But you know, if you make more close to medial, and if you get closer to the spinous process, your the vision and the maneuver and the surgical space is became poor. So you have to force your the device, endoscope, etc. So the main issue is how can preserve the posterior capsuloligamentous complex. For example, deep interspinous ligaments, superficial ligaments, and the bilateral capsules.
Oh yeah, so that's very good question. I think there are two deeper questions to this, two philosophy. Number one, so don't get away from the idea that UBE can correct alignment or do things like all adjacent segment degeneration should be solved by UBE. Number one is that these are frail patients who have mainly claudication. There is no instability. They are all properly assessed. So as a result, they chose to have UBE surgery. I have up to about 4 years. I think they are still okay. So not for all patients. If they're manual laborer, like Dr. Hayati say, maybe you can consider extension of fusion. It's not that bad. Of course, revision fusion do good outcome. So don't get away from the idea. Addressing the second question regarding the portal, these portals are also described in textbook. They are not like so medial to the in the midline where the interlaminar space. So when we put the portals a little bit more medial and closer together in the interlaminar space, it does preserve more lamina. However, we have to create a more spinal laminar dissection to create the space between the two scopes. Otherwise, we will be doing what I call parallelism. So you have to pull back the scope a bit so they can do work, and then you put in the scope and see. So I put it about 2.5 cm apart and a little bit not very lateral, still medial pedicle line. I think it's still in the acceptable range. I think I find this way that they don't really take down any interspinous ligament or deep ligament. I think it's similar. We do dock at the base camp at the base of spinolaminar junction, and you work from there. What I find is that in this type of area, probably we would need first of all, then my viewing portal can be constant, and then I just use the my right hand for the working portal. I find it consistently okay. Second of all, I think the facet resection, the worry part about facet resection, because we are more lateral, right? So we tend to take there's a concern of taking a bit more lateral, more facet joint so that we can see the ipsilateral side. I take that point, but I have done my own post-op CT and MRI regarding this technique. I think the facet joint is well preserved. I done I done hundreds of these cases. I have not had an instability. I do the best way or so, closer together sometimes when there's really a bit more foraminal and lateral recess stenosis, ipsilaterally. So I just adjust the technique accordingly.
Thank you. Thank you so much, Dr. Wang.
Okay.
Hayati, just to tell you what I would be doing, I would either take the ischemic or I would go down onto the superior edge of the inferior lamina. Make a small notch there, find the old flavum, and then strip up without disturbing the facet further. Pull back the dura and do a revision. That way I have minimum damage. Either I have to go on the ischemic side or I have to go on the superior lamina SAP side. Yeah, I agree with you. So then you don't need to switch portals, no. This is why I do this way. So I don't need to switch portals. Our next speaker, please.
Next speaker is Dr. Amit Thapa. He's going to talk to us about MIS surgeries in Nepal.
Respected chairpersons and dear friends. Well, I bring greetings from Nepalese Society of Neurosurgeons, on behalf of which I represent here. And at the outset, let me thank the organizing committee, the Endoscopic Spine Surgery Society of India, as well, in particular, Dr. Malcolm and his family, for being a wonderful host and organizing such a wonderful meeting. This is really a tough thing, and this whole environment actually vibrates with your energy. Well, my topic is to bring forward and highlight on how the program has actually developed in my place in Nepal. And since I work in an academic center, there are a lot of things which may be represented to most of you. So I have nothing significant to disclose regarding this presentation of mine. So I take minimal invasive surgery as a philosophy, because if I say it as a procedure, we are so much evolving. With every 2-3 years, we see new technology coming up in this field. So it is just like trying to pluck a mango, a first ripe mango of the season from a beehive. So you're not damaging anything, at the same time you are getting maximum. Well, there are two related things when we talk of MES. One is maximum working freedom, and as we see the technology evolving, we are looking a lot more working space inside the cavity, which is either being created by water or by the other media, as well as it should allow us some extension of our ability to extend our workspace. And that's how the MES philosophy is actually evolving over the period. Now, since being trained in microscopy, we were trained into that much extent that we were told that we could actually eat with a suction and a forceps food. But then what we found in endoscopy is that endoscopy actually brings the illumination and the magnification to the depth, and henceforth it increased the expanse of vision in the depth, which a microscope may not be able to do that. So, and then over the period, we have seen that there has been an increasing application of endoscopic procedure. Even though it's called minimal invasive, it is going in much more invasive proportion. And if you see the publications over the years, in the last 2-3 years, we are seeing expanding amount of publications in this field of endoscopic spine surgery. Now it has really become a necessity. This started with some exploration, something to adventure for, because we as a surgeon need to do something extra, what we are doing routinely. But later on, we realized that minimal invasive surgery is just not a fad. It is just not a cosmetic surgery. It has a lot of physical benefit to the patient, not only in terms of quick recovery, but early discharges, minimum rehabilitation time, cost reduction is there because you are not creating instability to the patient, and also additional advantages like low blood transfusion effectiveness, less pain, and motion preservation. And this has been shown sufficiently in many randomized clinical trials also, where they have compared the endoscopic and minimal invasive spine surgery compared to the conventional surgeries. However, there are definitely some challenges. The major challenges which we face as a learning period during my first decade of this practice had been the confusing names. Every year, with every new publication comes a new name in the field, and that's why the names have been very much confusing. Similarly, we were better trained in microscope. There was always a tendency to revert back to microscope whenever there was a problem in endoscopy in the initial period. And then we used to reverse to the open exposures. So this could be because of the lack of exposures and trainings. And of course, the initial cost of equipment. So this is one of the field which I realized that the business practicality has actually entered into the endoscopy much more earlier than any other field. Henceforth, we have very much procedure-specific equipment in literally every company which sells its equipment. So we end up buying a lot of equipment for a similar looking procedure. And that's why it increases the cost of equipment. And also there's a learning curve and fear of complications. However, there has been some attempt to demystify this particular confusion with the name, with full endoscopy, biportal endoscopy, and microendoscopy, and what we are now looking at is a UVE techniques. And also the AO spine has been very much aggressive in classifying the endoscopic spine procedures. Well, we see a lot of uses. In Nepal, we are using this MIS technique not only for the disc herniations, but also to an extent of dealing with the spine infection and spine tumors. And we are getting good patient satisfaction. Patient reported outcomes are better. And also the operative times, as we started this process, has started coming down with lesser morbidity and decreased birth rate. However, this transformation had been very gradual because we had a lot of investment to be done on equipments, and also the concern with the safety was there, and expertise actually builds upon with a lot of practice. So we started with microdiscectomy or microscopic use of dural repairs. And then we went on to a procedure known as hemilaminectomy, where we could actually attack the intradural pathologies by opening a very small corridor inside the bone. And then we started using tubular devices and then the endoscopic devices. So this paper of ours on MIHAM, or microscopic hemilaminectomy, was also awarded as the best paper, which we could actually approach the intradural tumors through a minimal 2.5 to 3 centimeter incision on their skin. However, this particular approach actually led us to the belief that we could go inside the intradural space even through small cavities. However, there was an inherent advantage of MIS techniques over this particular open technique, and that was the muscle dissection. So when we see the muscle coming back to its place, this is something which we never get when we are doing a subperiosteal dissection or when we are cutting through the muscles. And henceforth, we were now transiting more or less into these dilatation method of MIS or endoscopic techniques, where we are now going slowly into the intramuscular techniques rather than subperiosteal techniques. So this is how we started with our tubular methods of discectomy and removing the small disc, extruded ones, from interlaminar approaches. And of course, we had actually used mobile technologies like the Distando technique also in our scenarios. The little bit difference what I found in the Distando technique was this: since it allows us a two-hand movement inside the tube, we could actually place a neurocotton inside, play with the stuff very delicately, just like in a microscope, with the added advantage of better illumination and microscopy. Well, but then there's always a challenges when you're operating inside the tube. As my previous speaker did talk about the parallelism. So the instruments, one has to come out if you're putting the other instrument in. What we are now finding is the UV technique is much more better because it allows two instruments to be inside at the same given point of time, and that actually is a help. Considering the fact that we are the neurosurgeons who are operating with binostril technique inside the skull base, much better with much control, and a lot of dissections can be done. To this fact that nowadays people are doing 2 ports inside the skull, one from one side, the other from the other side, to go inside the ventricle, and they open up the septum pellucidum, just like septoplasty, and then they can operate inside the intraventricular tumors. So this UB technique is something which we are looking forward to, and I'm very thankful to Dr. Malcolm, his initiative in this particular part, that we in our country are also trying to bring this UV technology to our place, which we're finding a lot more benefit. So contrary to the philosophy to mitigate the collateral tissue damage and stabilization and avoidance of fusion, we are now looking at the role of endoscopy to assist in fusion technologies under vision, which is never heard of. Even in MIS, there's a step in which you are rimming the end plate, you are putting the cage without any vision as such. But then in UB technique, everything is under vision, which is absolutely fabulous. So, but then there's always some challenges. So we require some equipments to go ahead with this technology. And then there's always a radiation overexposure, which we all risk. But then these all are relatives with the use of navigation technology, as in case of C1, C2, C1 fusion, we could only do away this procedure with just 4 exposures of fluoroscopy. We find there's a learning curve, but then this again is relative. The best part is that this technology was developed in Asia, and as an Asian neurosurgeon, we are proud to say that this technology is here to stay, and we are going to evolve it further. So to conclude, endoscopic spine surgery is not a specific procedure. It's just a platform where it facilitates better visualization and access to the spine while mitigating damage to the surrounding healthy tissues. And it has a role in mitigating the cost of treatment. It has a direct to consumer appeal, and with the supported technology, the navigation and automation tool, which assists surgeons, we can see expansive growth in this technology in years to come. Thank you for the patient listening. And on behalf of NESON, I'd like to invite for the next year's meeting. It's an international meeting in September 2023 in Kathmandu. So a brochure will be circulated soon, and I will send it to all of you. Thank you.
Before you announce the next speaker, dear audience, we have with us Dr. Seok Bongchung from South Korea. We welcome him. He's a master of UV spine endoscopy along with Dr. Hayati. We have with us Dr. Mihir Bapat and Dr. Vishal Peshetiwar and Dr. Amit Jhala. They are the doyens of spine surgery in India. I welcome them.
The next speaker is a virtual talk. Is it Dr. Oh, that one is off. Okay.
Dr. Balgopal from
Dr. Balgopal Kamachara for para UBE for foraminal pathology. Yeah, pardon me if I pronounce your surname incorrectly.
Respected moderators of the session, first of all, I'd like to thank Professor Malcolm and the organizing team for inviting us to this August gathering. So I'll be talking about use of transforaminal endoscopy in cases of spondylodiscitis. Spondylodiscitis can be infective or tuberculous and sometimes post-operative. And tuberculous spondylodiscitis is quite common in our part of the world. So I'll be going to present 2 cases of spondylodiscitis, one thoracic and lumbar, which were managed transforaminally. In dorsal spondylodiscitis due to TB, the patient may present with severe pain due to instability, then myelopathy and radiculopathy. And then because of the paraspinal abscess, these are the results. And despite the good ATT, the written disc fragments can impair the bony fusion. There is a lot of morbidity of open surgery, so there is role of transforaminal debridement. So this picture shows the chronic abscess in D9, D10 area because of tuberculosis.
The slides are not moving.
Just 1 minute, yeah.
Sorry. So as you can see, this is a like chronic abscess with destruction of the hand plates in D9 and D10 area with compression of the cord. And this picture shows the position of the needle, cannula, and trocar for the transforaminal approach. The approach is usually 5 to 6 centimeter from the midline, and the entry is just above the rib head. So the entry is directly to the disc space. And in this video, you can see that there is a lot of pus that drains through the cannula, and you can do thorough debridement with irrigation, and then can remove these sequestrated bone fragments. In the lumbar spine, tuberculosis is not that common, but sometimes we see. These patients can present with large psoas abscesses, then large extradural abscesses with weakness of hip flexors and quadriceps, and most of the time patient might not be able to ambulate because of neurological deficit or weakness. So in this picture, we can see the destruction of the end plates, and then the paraspinal collection of pus and the compression of the spinal cord. And this can be also drained with the transforaminal approach, and the thorough debridement of the disc space can be done, and if required, the fixation can be done to reduce the post-operative pain. So compared to open technique, the transforaminal approach has many advantages because it can be done under local in patients who are morbid, and drainage of pus can be done with the small incisions, and we can put also a drain, and we can avoid the morbidity and mortality of open surgery. Thank you.
I have one question for you, Dr. Balgopal. Are you not scared of fluid leaking into the pleura when you are using continuous irrigation in the thoracic spine? How do you manage that?
So usually these patients are operated when they are already under ATT. So usually the cavity is a chronic one with formation of a like the wall. So the chances of perforation to the pleural cavity is less, but it should be like, it is very easy to perforate. So you should be very careful that you do not puncture the pleural cavity.
Thank you. I did one in an infective spondylodiscitis, and I had a perforation. And I suddenly see that fluid is getting sucked into the chest through a hole on the opposite side. I'm pushing more fluid, it is going away. So I hurried up my surgery, and on table, I had to put the patient on an ICD and covered with antibiotics, but the patient stabilized, did very well, and became pain-free. The one thing that I've noticed, thank you, doctor. One thing that I've noticed in spondylodiscitis, whether it is infective or tuberculous, especially in infective, is that pain just disappears. You put in a scope in any patient of discitis, whether it's your own discitis after a foraminal surgery or of any other nature, moment you put in a scope, moment you clean and debride there and wash it out with a few liters of water or saline, patient will wake up with almost 90% pain gone. But the only problem remains in transporting the patient to the theater, because he's screaming in pain at that time, and in turning him. So therefore, all spondylodiscitis surgeries, I prefer to do under general anesthesia, because that is the only way I can turn and position the patient in a prone position. So that is the only problem I faced. But otherwise, whenever I have done a surgery for spondylodiscitis, I have been blessed with excellent results. Post-operative monitoring is only by CRP and PCT. Both when they reach baseline, I stop IV antibiotics and put the patient on 6 weeks of oral antibiotics. Usually fusion is not needed, because if there is not much of bone destruction, what we have seen inside is that although the nucleus has disappeared, the annulus is quite intact. And though there is a little collapsing of the disc eventually, and maybe secondary foraminal stenosis over a few years, patients generally do well. So I don't have to need to fuse it unless there is major bone destruction and tremendous instability. So that is a very different spectrum of cases. I'm just talking of normal patients, early picked up patients of spondylodiscitis. Yeah. Yes, that's why I said the patients do well, sir.
I'm sorry to interrupt you. Yes, it's very important. Our young colleagues following us, we just talking about the indications. We have very wide indication spectrum, etc. But we should know about the contraindications of endoscopic techniques. You know, mainly we have actually two main endoscopic technique methods. The air medium, maybe we can say the tubular system, and the fluid medium. So for the fluid mediums, the endoscopic systems, fully endoscopic or biportal, etc., the uncontrolled infections and the primary tumors contraindication. We should know about that. If you be sure about the infections, and if you have a good the door to reach the infection site, far from the spinal cord, maybe you can choose the fluid medium endoscopic technique for infections. Thank you.
Thank you very much. That is really insightful, sir.
I'd like to welcome Dr. Andreas Sanagra from Argentina.
Hello. Good afternoon again. First, I want to thank Dr. Pestonji for the invitation. We are really honored to be here. We have a very long trip, so my brain is arriving tomorrow. So please be merciful. Okay. As we were talking today, we use epidural we have been using it for a very long time. So we have mastered the technique, so we still use it. Though we have changed it for transforaminal and translaminar approaches, we still use it in some cases. mostly combined with transforaminal approaches. I will show you the use of the endoscopy in spinal cysts. You know that lumbar cysts are mainly perineural and synovial. You have an endoscopic view of a synovial cyst on the right. Synovial cysts can be lateral, so they compress the nerve root and in the recess, but they can also be posteromedial. The incidence is 2.2 to 10% in series, most prevalent in an L4, L5 level. You can see it on the right. And perineural cysts or Taleb cysts are mainly sacral cysts, which are usually asymptomatic. They are filled with the CSF and are mainly appear in the sacrum. We know that they scarcely do make symptoms or have symptoms, but when they do, epiduroscopy is a great way to approach them. You can see them, they are hyperintense in T1 and hyperintense in T2. They are very easily diagnosed in MRI. Lumbar cyst can give symptoms because of compression of the nerve roots mainly, and of course it depends on the volume of the cysts. They can give unilateral or bilateral painful radiculopathy. Many cysts, especially facet cysts, can be approached with a needle. That is a usual question. Why don't you think just a needle and a facet approach to take facet cyst? But epiduroscopy for us is a very easy procedure, which takes exactly the same time that using a needle and radioscopy. And it's more helpful in cysts that are posterior medial, which cannot be reached with needles. Which is a technique of epiduroscopy, the infiltration of sacral hiatus, the insertion of the trocar. I will show you this afterwards. The incision is a very small incision, 5 millimeters. We insert the epiduroscope. We localize the cyst. We used to open the cyst wall with laser or with the forceps. And then after the cyst has disappeared, we use medication in the epidural space to treat pain. Here you can see the insertion of the trocar by a small incision by puncturing the sacrococcygeal ligament with a 2A needle. I can show you here down in the picture down there. You can see with radioscopy the position of the needle. Actually, we don't really use fluoroscopic guidance anymore. You can see the OR here, the flexible endoscope, the laser over there. You were asking about the laser in the top, and the insertion of the trocar and endoscope there. When you insert the endoscope, you can see it here in the, well, okay. I want to show you the video. That isn't working. Well, I'm sorry. I need to figure this out. Oh, but there you see it. I can see it here, but there you can see how the progressive position in the middle line and the endoscope is entering. We use a very little infusion of a volume of saline solution. There's no need to infuse too much saline solution because you have very good pictures with small infusion, and that avoids pain when you infuse quickly or as a great amount of saline solution, there is pain, and it can also increase ICP. So we use only a little infusion of saline solution. Okay. You see the OR and the instrument we use. Yes. I'm sorry. Okay. Here you can see how the catheter is advancing the placental area. And this video shows you how we can move the catheter from one side to the other and work on both sides. You can see the catheter entering the space and going through the ventral area. Here you can see how we enter the canal. We rotate the endoscope, and that allows to enter other tools to open the cyst. There you can see how we enter the laser tip. We usually make small holes on the wall of the cyst to lower the pressure, and then we can enter other tools like I want to see there, a grasping tool to take all the rest of the capsule. You see the bubbles too because of the laser. Okay. This picture shows a successively of the first one is the cyst, the first approach to the cyst. Then how it is open, it lowers the pressure, and the last picture shows there's no more cyst and the root is liberated. This is another endoscopic picture of a facet cyst comprising the root. Another one, synovial cyst. You see the root over there and the cyst underneath, comprising it. The procedure takes around 60 minutes, no more than that. I will show you a case report here. It's a woman of 50 years old with a left LFS1 radiculopathy of 1 year of evolution with no response to conservative treatment. You see in the AP view of the MRI how it is comprising the root. It was the only cause of pain in this patient. We are entering the tunnel there. You can see in the top the references of the cyst. Another case report, a 65 years old woman with a right L4, L5 radiculopathy, 1 year evolution. She had pain that alleviated with sitting or lying and no response to conservative treatment. You see the MRI there. This was the image of the cyst when we enter the canal. So you can see the Fogarty balloon. We inflate it to bring the cyst. So you can see the cyst and the radicular nerve underneath. And the last video, we have lowered the pressure of the cyst and we had freed the nerve root. We have another case report here. You can see a lateral fasciculatory cyst. We enter the canal. We rotate the endoscope to allow the entrance of other tools to work. That is the laser fiber. As I said, we puncture in many places with the laser, and after the pressure is down, we can take the laser wall with forceps. This is another fasciculatory cyst. You can see it's quite postural medium, so this is why it's easier to use epidural in these cases. You can see the video there. We enter the canal, we rotate the epidural. The cyst is on the right. And after it resolves, you see the pictures down there with no cyst and the radicular nerve is freed completely. The conclusion, epiduroscopy is a safe ambulatory procedure with minimal complications, which can definitely deal with pain associated to lumbar cysts. We use this procedure, especially in older people, with morbidities, with many comorbidities, which make conventional surgery difficult, even transforaminal surgery difficult. Thank you.
I have a question for you. How
Yes.
often do you see a recurrent cyst occur?
Recurrences
Yes.
of cysts, of Charlotte cysts, never after opening it. We never saw a recurrence. With fasciculatory cysts, we do see, because sometimes, it is associated to instability of the segment. So many patients need afterwards another procedure. We use it especially in patients which only show radiculopathy. In those cases, patients do very well only with this. But afterwards, it happens that if instability is not solved, they usually reappear with fasciculatory cysts.
Thank you. And technique-wise, with the facet cyst, do you typically treat that with a laser to destroy as much tissue as you can?
Yes, absolutely. It's very safe to use laser. Our laser fiber only gives heat in the point, not around, so it's even safer than radio frequency, and we never have complications because of the use of laser. Maybe a transient dysesthesia, but only that. Thank you.
Thank you, Dr. Andrea. I think the next session is live surgery.
Can we connect to the theater, please? Dr. PC Day is going to start his Destandu, and he's going to do some positioning for Destandu. So Dr. Rohidas will be moderating for us. Thank you.
This is minimally speaking.
पैसे के लिए सब कुछ करो
We are having about a 10 minutes delay from the theater. So in the meanwhile, can I please request Dr.
Satyan Mehta.
Satyan Mehta to give his talk, but Dr. Amit Jhala and Dr. Amit Thapa to please chair the session.
Jhala sir, we are all your students. Come up, sir. No problem. So good evening, everybody. Thank you to the organizers, first of all, for inviting us and giving us the opportunity to present here. Especially special thanks to Dr. Malcolm Pestonji, sir, for the organizing a brilliant meeting here. My talk is on doing a posterior cervical microforaminotomies. So consider this patient who is a 56-year-old female who's got a left-sided neck pain and upper limb radiculopathy. And she's not responding to steroids, physiotherapy, etc. And at this stage now, this is what her MRI picture looks like, where you can see a proper left-sided C6-7 disc herniation. And conventional treatment would tell us that we would go for anterior cervical discectomy and fusion, or maybe even if you are Dr. Mihir Bapat, disc arthroplasty, because your patients demand so. But this patient does not have any instability and no collapse at the affected level. So the option that we will be doing, which I have gone for, is a discectomy, which we are going to do from the posterior cervical approach through a microforaminotomy incision. Now, what is the indication for this here? First of all, what are the contraindications? So this kind of case cannot be done in hard discs. It's more difficult to do in central disc herniations. And if they are older, long-standing disc herniations also, it could be a problem. But this is one which is paracentral. It is lateral to the cord. It is a soft disc and it's relatively recent. So this is probably the ideal case to do this procedure. In positioning, the patient is positioned in prone position, as we routinely do in posterior surgeries. And we have to straight away go on to the interlaminar area here. So that is where the main problem lies, and that is where you need to dock. So you may want to use a scope here, a tube here, or you can even use a McCulloch's retractor, which I have done in this case. The reason for why I'm talking about using maybe a McCulloch's here is because these patients often tend to bleed a lot, and there is a venous congestion, and that could cause a lot of bleeding. And so to tackle that sometimes could be very, very difficult if you are just doing through a tube. Once we get that in, we need to take a burr and start burring the medial end of the facet and a little bit of the lamina to get to the nerve root. This is for the sake of vision. This is the easier way to do it. This is your at your 9 o'clock is your medial position. At your 3 o'clock is lateral. And this is how we've gone inside. We are burring off the part of the facet and the interlaminar area. So the lower part of the upper lamina is burred off so that we can start seeing the edge of the ligamentum flavum and then the dura and the nerve root. Once we get through that, then the disc herniation usually is lying right there, and that could be, and you just need to go on that area and hit it and get that out. So this is your vision where we've done a wider decompression here, taken a bit of the flavum out, and we are exposed the root, and we are going to be following it in. This is the inferior part of the root where usually the disc herniation fragment lies, and that is where we will have to go in and tease that part out. There is usually a lot of venous flexes going on this area above the nerve, and we need to burn that off, and so that the bleeding is controlled, because once it starts bleeding, it's quite difficult to control it. As I was discussing, this is the inferior part where we are just going to tease that piece of disc out. So you can use a blunt probe, or you can use a sharper hook also to get that to start teasing that part out. And this is how the disc, the herniated disc which has been teased out, comes out. If you are a little bit adventurous, you can even use a little small osteotome and open that disc up so that you can get more disc out from that area. So the advantages of this procedure is obviously that you avoid a fusion. It's a much smaller procedure, very low cost. Patient starts moving the same day and can be sent home the same day itself. But the disadvantage is that this cannot take care of your stenosis issues. We are not able to distract the disc space and give a lot of space to the foramen. So, and the chance of recurrences are more. Also, if you may sometimes get stuck, and if it's a chronic or a long-standing disc, there is a chance that you may do a inadequate discectomy. And also blood loss, bleeding can be an issue if you're not very careful. Thank you. Sir.
Thank you, Satyen. Very nicely described the procedure. I think one of the procedures which I would say, which is competing the disc replacements in a young patient with a soft disc herniation. The only thing is, why do you say that there is a more recurrence with posterior? That's what you mentioned.
I'm not saying that there is more. There is a chance of recurrence, which would not be there if you do a fusion.
Oh, compared to fusion, but there are so many reports that they have said that there is very less chance, because as such in the cervical spine, the disc space is very less, and you remove a very small fragment, the chances of recurrences are very, very less. So, any other questions?
Thank you, sir.
I have a question.
Yes,
I'm Dr. Chang in South Korea. I think it is difficult to retract the cervical muscle. I saw your retractor. It is so unique. You make the retractor by yourself?
No, this is the traditional retractor. The one which I've used for this video is the traditional.
One is Spino's process?
Yes, this is the traditional retractor which we use for the lumbar spine, the Mechalux retractor. So we've just modified it and used it in the.
So there's a hook on one side and the blade on the other.
Interspinous.
Only.
Yeah. So you're so advanced that this is an old retractor that you're not aware about it.
Yeah. Thank you.
Okay. Thank you, Satyen. May I call the next speaker, Vishal, to speak on MIS in high-grade spondylolisthesis. I think everyone knows Vishal is working as a consultant spine surgeon at Kokilaben Ambani Hospital.
Can you hear me now? Yeah, hi. It's great to be back to Holy Spirit Hospital. I started my journey as a spine surgeon here nearly 20 years back. Thank you, organizers, for having me here again. High-grade listhesis is usually something that has been a challenge even in the open era. This is a case of a morbidly obese patient with a grade 3 going to 4 listhesis. I had done this about 8 years back. These are Indian implants that we've used, and that's the fusion that we saw at the end of 2 years. You can do this with simple tubular retractors using fluoroscopy, or you could use kind of 2D navigation, or you can use 3D OARM, which we use now. The basis of doing this via minimal access surgery is to restore the anterior weight-bearing structure. A lot of people believe that the screws will do the reduction and hold the reduction, which won't happen. The weight-bearing structure, any architect will tell you that the weight-bearing and torsion are two different surfaces. Posterior surface in the lumbar spine is where the torque limitation happens, whereas the weight bearing happens in the anterior and the middle column. So unless you restore that and put a compression sharing device, you're going to be in trouble. This is the phenomenon that we try, like this is a postulate that we use. So if this is one end plate and that's another end plate, and that's the listhesis you have to distract this to its original position. So all soft tissues have a finite length, especially annulus and the ALL and the PLL. So as you distract this, they work like a ligament rotaxis. Similar thing, orthopedic surgeons are very familiar when they fix distal and radius. So as you do it, then you restore it back to its height, and then you put in an adequate size cage. So what happens essentially is you have tight ligaments on the side and you have a weight-bearing cage in the front. That causes a stable weight-bearing construct. And then you put in your screws to hold this. The chances of this surviving are much higher. This is not exactly grade 3, but as you can see, is a very stiff listhesis. I'm just going to run through the video, standard Jackson table to give position so that the abdomen is free. This is a fairly robust patient. This is a marker X-ray we take to see the position. The patient has been given head height so that this space is 90 degrees to the floor and it's easy to work with a microscope. Once you have localized and marked the landmarks on the skin, I use a Thompson tube, plenty of tubes that are available in the market. Once the serial dilatation is done and the tube is in its place, that's the orientation. So that's medial, that's inferior, that's lateral, and that's superior. Where you're seeing that's the facet joint, there's a pars somewhere there. So that's the chisel. You can use a kerosene, you can use a Leskel. I prefer a chisel because it gives you sharp cuts, and the chances of damaging the dural structures in a stenotic canal are much less. So that's the picture-in-picture view is showing what I'm doing, whereas the microscopic view is in the larger frame. You get plenty of bone graft when you do this. That's the inferior facet of L4 coming off. And this is what you see inside. You can use a kerosene rounger to just smoothen up the sharp edges if there are any. Then you need to see this tip of the inferior facet. Unless you see this tip, you're not going to be able to excise it. Here I'm using a Leskel nibbler. The reason is if I use a chisel here, the chances of it breaking into the pedicle are much higher because this bone, as you can see, is extremely soft, and then you would lose the pedicle hold on that side. So once this is the cambium strangle that we are opening up, once this is open, this is the area where you need to enter into the disc space. A little bit of wax, as in osteoporotic bones, the sinusoids are fairly large and you can have some bleeding. So that's bone wax to help to stem the bleed. Using a curette to take the phlegm away. Since these are chronic pathologies, you'll find a lot of adhesions there. It's always wise to release and take time and be patient here and not try to be doing this in overdrive, because a dural tear would set back the patient's rehab by a few days. Once there is enough, sorry, I'm going to skip this. So that's the flavectomy done. Once you are able to see, I'm using a 15 number knife to get in. I can barely get that inside. That's how small the disc space is. You have to patiently kind of open it up just to give you the perspective. Then we'll be using a number 4 Penfield to check the direction of the disc space. Once you've taken up the annular cut there, just to check where the disc space is. It barely takes that number 4 Penfield. And I tried to open it up with my Puka chisel couldn't open it because this is 2.5 millimeters wide, but even this was so big. So we used a 1 and 2 millimeter kerosene rounders to open up the superior part of the inferior vertebra. This is a 3-0 lumbar curette, which is then used to open up this space slowly. As millimeter by millimeter, you can make a small tract inside. Once this tract is done, and you can then negotiate a 2 millimeter pituitary rounder, as you can see it here. This is the time then to bring in your blunt puka. This puka is a blunt, and sorry, this still you're using a curette to opening this up. I'm going to skip it a little bit. So that's the puka chisel going in. This is 2.5 millimeters in, and as you turn it, it jacks up to 6 millimeters. So that's a gradual distraction. We have them in 1 millimeter size up to 16 millimeters. So depending on how much it takes to get the distraction perfect. Once this space is made, again, putting in ring curettes to get the end plates prepped. This is the most important part of a fusion. If your end plates are not prepared, however good cage you might use, it is never ever going to fuse. So this is a gradual distraction, millimeter by millimeter. You leave in your puka for a couple of, not a minute, maybe 30 seconds to let the soft tissue stretch, because if you try to do it too fast, you'll end up with an end plate fracture. There will be some bleeding every time you turn the puka in, because that's when the epidurals will open up. So that's the physical part of it, and that's what you see in the microscope there. So this is, I think, the last 12 millimeter puka that we're putting in, because you can see the resistance that you get while trying to move that in. So that opens up the disc space much better. Yeah, so this gradual jacking up, it's like raising a car to change your tire. You're using a rotatory force to get height. That's what you're doing here. You have to be very aware that this is not an end plate shaver. This has to be a blunt puka chisel. Otherwise, it's going to bite inside your end plate, and that's going to be the end of your ability to reduce that fracture. That's the last one. Once it's done, you leave this in its place, turn it. This is where it gets tight. You know, this is the maximum pressure that the end plate will probably take. Beyond this, it'll start crumpling. So that's where you stop. You leave it inside for some time. Let the stretch come in. You can see now this is a 12 millimeter wide nerve root retractor, and that's how much it's the puka is, and that's the optimal stretch that you get. This comes with use of time. You'll get a feel that, okay, beyond this is probably it's going to fail. So once you take this out, again, go to the opposite side, use the curettes to clear the end plates on the opposite side, use an up-facing curette to take out, scrape out the undersurface, a down-facing to go to the opposite side. Once this is done, there is enough space for graft to go in. So that ensures that this fusion is going to happen. So once the end plates are prepared, we will put in the bone graft here. Mossealized bone graft, you have to remember that you cannot make bone graft very, very small, because apart from an osteoconductive effect, bone graft also has an osteoinductive, it also has an osteoconductive effect. If you smash it beyond a 4 to 5 millimeters, it's going to lose the osteoconduction part of it. Bone grafting with a funnel so that it goes inside the space it is expected to be. And once the grafting is done, you have, in this cases, to use a trial. The trial pushes the graft away from the part of a softer peak cage that you're going to use. This is impacting the graft to the opposite side, and then using a trial. When you're going to put in a trial, expect it to bleed, because the epidurals are going to be opening up. You're making space now in the canal here. This is what is called, would be leading to indirect decompression of the opposite side. So that's the using a bit of cotton patties to stem the bleed. This is when you check in your C-arm about how well the reduction is and how the cage is sitting inside. And once that is done, use a bullet cage to put it in. So once it's checked in the C-arm, you take this out, and so every time you take the cage out, the blood that's there in the disc space is going to come out. So don't worry, just suck it out. It should be fine. That's the bullet cage going in. A bullet cage with a longer nose helps going in easy. And there it goes in. So you don't need any special equipment for this except for maybe bayoneted instruments. And that's it. That's the cage going in. As the cage goes inside, you'll see some amount of bleeding. That's okay. You can then take care once you're disengaged there. This is over the top decompression, which is fairly standard. So I'm going to skip it. Percutaneous screws, I'm sure most of you are familiar with. We use O-arm navigation to get in there. That's the over the top decompression. You can see me using a 3mm ballpoint in the opposite cortex and under the opposite end, seeing that there's a proper expected decompression, because unless you have done this in a high-grade listhesis, the opposite facet is going to take the traversing route and cause a problem. So that's an O-arm. Once you take a spin, this is how the screws go in. You make a small cut, and there is a lag in the video. I'm extremely sorry. Yeah. So the blue part of it is the needle, but the yellow is the projected part. So that's the projection of the screw, and then it's fairly standard way of fixing the spine, and that's how it goes. What you see here is what is seen in the navigation screen, and put in a wire, repeat the steps in other 4 places, and then hold on the wire till the rest of the things are in place. Once all the 4 wires are in, then standard dilate over the wire, do a tap. You can see the tap real time as you do this procedure. And so percutaneous screws navigated have changed the amount of radiation that we normally take in a proper MIS fluoroscopy unguided surgery. So real time, you'll be able to see where your tap is going. So the chances of putting a wrong screw are practically negligible. Wrong level surgeries go down. And soft bone, so we'll just tap probably to the base of the pedicle. And then once that's done, pass in a screw in its place. So barely any blood, soft tissues are not traumatized, what would have been in an open surgery. I'm not using a proprietary Medtronics screw here. So you can only see this advancing once these glions are facing the navigation, but it gives you a fair idea of where the screws are going. Also, you can see that my screws are way medialized compared to a normal screw, which would go straighter. I'm starting way lateral and going in way medial. So that's the advantage of having a navigation. You're able to put longer, more safe and fatter screws to get a better purchase. And this step is repeated in all the 4 pedicles. And that's a fairly acceptable final position. So these screws are like elongated reduction screws. K2M came up with this, and then a lot of manufacturers, now that the patent has expired, have started using this. The advantage of this is you can use the screw as a reduction screw, and that helps you. That's the lordose rod. It always helps to lordose your rod further. Medtronic system like the Sexton doesn't allow you that. It gives you a fixed lordosis. That is what has caused epidemic of adjacent level because of hypolordosis at the level of fixation. So you need to bend your rods more to get a little bit of more lordosis through the screws behind and get that compression. This is made in India system by Jesco, fairly good in its job. And that's what you do. You first tighten up the lower one and then tighten up the upper one. So that little bit of reduction that is left, you get through that. And fairly simple procedure to do once the interbody work is done. Once both the levels are fixed, you just take a check shot, and that's the final screw construct coming off once the rods have been inserted on both the sides. It's a very clean surgery to do. It is not a surgery you would want to start your minimal access journey with. You should do it once you have done a fair number of minimal access tubular decompressions, because it is more demanding than an average TLIF, which is very quick and very simple and not very difficult to do. And that's what we got at the end of the procedure. You can do it in multiple levels. This is one of our doctor colleagues' mother. This is another MIS TLIF done with again Indian implants. This is another high-grade listhesis. This is now more than 6 years old, a syndromic 75-year-old. This is a squatting and sitting cross-legged. Culturally in India, these are the two positions they want to use a lot, and we are able to give it to most of our patients. The reason, even in osteoporotic bone, you can allow them to do this, where it is putting a lot of pressure on the junctional level, is you have restored all the abnormalities that could cause a distortion here. So the screws actually don't take that much weight as much as the cage does. We have published this paper. These are some of our CTs as a standard in our institution. At 6 months, we take a CT scan of every patient to judge the level of fusion. In the past 5 years that we are documenting as a single institute, single surgeon series, we are now close to 100 cases of high-grade listhesis. We have been lucky so far. We've not had a case of non-union. We have about 6 or 7 dural leaks, but our blood loss has been very, very low. The surgical time has now come down to less than 2 hours because of navigation. Of course, the radiation risk has come down. The short to medium term reports. Now, the first MIS for high-grade listhesis was done by me and my partner, Dr. Devesh Dholakia, nearly 10 years back. So our total caseload is probably over 100 cases, 50 of which are more than or at least 4 to 5 years old. And all of them seem to be doing much better. Of course, there is dural leak issues. There are issues of delayed union. But so far, as compared to an open surgery where you would go a level above, fix to the pelvis, put an iliac screw, this has worked even in patients with scores up to -4. Thank you very much.
Thank you, Vishal, for a very nice video. Any questions? Yes, sir.
I have a question. Good presentation. Grade 3 spondylolisthesis, lytic. Always we should be careful of upper level exiting route. You always check the upper level exiting route during operation?
No, I don't. Actually, see, if you have a dynamic listhesis, it is the movement that hits the root. The exiting root is actually going to just go below the pedicle, whereas the non-union and a pars is going to be a little below that. So once you've fixed it, it's a stable construct. So if you have a rough surface and you have a hand that is moving, it's going to irritate your hand. But if you have kept your hand here, the irritation is going to be much less because you're not moving. Initially, in the first few cases, we would always go over the top, see into the opposite foramen also to see that the exiting root is free, and then go up here and do it. The cases where we didn't do it have less burning pain because you don't handle the ganglion that much. The moment you reduce it, the annulus which is encroaching up all falls back. So the pressure on that root is gone. So the exiting root actually is the one that does well if you have put an adequate size cage. If you put a short cage, that's when you need to de-roof it completely and see right up to the exit, because your annulus is still going to make a flap that is going to hit it all the time.
Maybe I think when using a big KZ, higher KZ, at that time is exiting is always sometimes tenting and medial migration. So should be careful of exiting.
So it's basically to use an adequate size cage. So if you use a large cage, you're going to be in trouble because that's going to distract. If you use a short cage, it's going to put pressure on your screws because it's not a load-bearing cage. So ideally, in the first few cases at least, you should always take a C-arm shot to see what is the restoration happening. And if the above or below disc is normal, you can use that as a reference to put in your cage to near. But I agree, any cage that is standing proud is going to cause a big problem to the nerve root there. Thank you.
Vishal, can I ask one question? Does your technique change if it is more than grade 3 listhesis and in a dysplastic one? Because this is what you showed was more of a degen always or a lytic type of a listhesis.
So we have to be very honest, done very few dysplastic ones. Dysplastic ones are the ones that are very stiff in most of the cases. Fortunately for me, with O-arm, I can still put in good screws even if the pedicle is short, which usually happens in a dysplastic L5 pedicle. In cases where it is so stiff, what you do is you dock your tube from both the sides and do bilateral osteotomies. And then you use the pukas on both the sides. So the pressure is much less. If that doesn't help, then you got to take a bent chisel. It's actually very easy if you're going paracentral, because once you're going central, going to the top and doing a sacral dome osteotomy, you actually can't see it much because its vision is very little. But when you're going paracentral, you can actually see the dome. You can adjust your microscope to that, and you can just knock off the chisel, or you can use an angled cervical curette to dissociate the anterior part of the annulus from S1. That helps, and that gets you the reduction most of the times. So far, we've been lucky. I'm hoping that we don't come across a case, but a case, we've had rheumatoid arthritis cases where we found they were very soft to put in a cage or something. What we do in that case is we just decompress the exiting route through. Don't put a cage in the front, pack it with graft, and put a bone-on-bone reduction. So the foramen is very small, but because it doesn't have a roof, the root is clean. So the patient doesn't get radicular pain. At the same time, bone-on-bone is the best stability you can get. So it's like kind of a hybrid procedure, but MIS works well.
Thank you very much.
Thank you.
So I'll call upon Dr. Narendra Bhagwat.
Amit, they are ready in the theater.
Yeah.
So
you can...
Thank you, Dr. Vishal. It's nice to be at home after many years. He worked here in this hospital. How many years back? 15?
Sir, please start.
PC. Dr. Day. You are visible.
Dr. Day, can you hear us, please? We'd like to hear you. Hello, OT. Can you bump up the volume, please? Dr. PC Day.
Little loudly. Hello. The volume is. Hello. Can you increase the volume?
Hello.
Hello. Yes. Yeah, you are audible. Please start.
Thank you. So patient, I'm just going to explain the X-ray first, then I will show you the positioning and the localization.
Okay.
So focus the X-ray first. Here. So X-ray shows it is patient is a 37 years lady, complains of the left side more mild pain the right side for last 3 years, and there is a claudication also about 10 to 15 minutes and about half kilometer 1 kilometer walk, and she has severe pain in the S1 nerve root, L5 S1. X-ray shows there is a extension, flexor extension normal, and the lateral view shows this L5 S1 very small.
Can you increase the volume?
Root, left side nerve root. Can you see this one, L5 S1? Hello?
Yeah, that is L5S1. Okay.
L5 S1 left side. So I'm going to, this is also a long standing, maybe the lateral canal stenosis, paracentral stenosis, lateral canal stenosis, and also the disc, small disc in the left side nerve root. Now I'm going to show you, I'm putting the patient in the knee chest position. So this is the knee chest position, and my C-arm is in the lateral, not AP. We are not taking any AP view. And this is the localizing device I'm using. It has 3 bars, these are 2 side bars, and in the center bar. These 2 nerves in the both side of the spinous process, and I'm manipulating this lateral bar side to side. And with the help of the C-arm, check the C-arm. So this is the positioning. Sir. Okay, now focus that one. Focus. Udhar dekha. Right. Good. Hey, udhar chhod de, udhar chhod. Good. Good, sir. Absolutely. Good, sir. So this is L5S1, right? Hello?
Hello. Yeah.
Yeah,
You are able to.
L5S1, and then focus here. Hello. So So I have given this using this ball pen, simple ball pen to put the marking, and I have given this marking. This is the center or midline, and this is my approach here with the incision about say 18 to 20 millimeter incision, about 12 to 15 millimeter away from the midline. Are you able to see me?
Yes.
Okay. So now this is the knee chest position. Anything else you want to ask me? Otherwise, I will leave. I will go for the ducking the instrument. Then I will call you back maybe after 15 minutes.
This is the position which I am using it since last 25 years. Even if when I was doing my open surgeries, I used to use this.
Knee chest position on the ball star. This is a simple cushion. This one is a simple cushion, and patient is sleeping the chest and head on the cushion, and there is a small cushion at the between the thigh. And the leg.
Anybody has any question about this positioning or want to discuss anything else about the positioning and localization?
Increase your volume, please. Hello.
Okay, PCD, they don't have any questions.
Yeah.
So carry on with the preparation and yeah.
So you proceed with your talk. After 15 minutes, I will call you back.
Okay.
Thank you.
So we move on to the next speaker, and there's some change in program because I have to give a privilege to Dr. Mihir for a special day that he has today. So I'll invite Dr. Mihir Bafat.
Thank you, Dr. Jhala. It's an honor here. To be very frank, I didn't know this was a physical conference. So, so I've recorded my talk, and I'm going to be minimally speaking in true terms. Can we have the... this is just a variation of what Vishal just showed. And to answer a few questions which were raised about the exiting route and the difficulties that you face in tackling dysplastic listhesis. I have a second talk where we have applied this to dysplastic listhesis also. And that talk is on Sunday. So this is just the technique. It's an hybrid technique. It's a microfenestration approach, which is midline coupled with screws. So that's a simple philosophy. Hybrid. What is this? Video. Yeah. Now don't tell me it's not pink. Yeah. We present the case of a 55-year-old gentleman. We present the case of a 55-year-old gentleman who had progressive deterioration of action over the last 2 years and left buttock years. The X-rays showed a grade 1 listhesis, which was dynamically unstable on the flexion views. The MRI showed a degenerative L4-5 disc bulge with facet hypertrophy, with mild facet effusion and a broad-based disc. A fixed needle marker is inserted into the spinous process of the cranial vertebra, preferably at the level of the superior end plate of the disc. The percutaneous screws are then inserted separately, depending upon the AP projection. The screws are adequately lateralized so that there is optimal distance between the midline and the insertion of the screws. The trajectory of the screws is anatomical, sparing the facet and allowing optimal convergence. The entry points may need to be staggered depending upon the size and the rotation of each vertebra. This is allowed by this particular technique so that the screw insertion can be selected as per the anatomical variations. After all the 4 wires are inserted and the wires have been anchored to the drapes of the pedicle, the midline needle is then cut left in situ, and the dissection is carried from below the level of the needle to the superior tip of the inferior spinous process, which is the true fenestration approach. This is about 1.5 to 2.5 centimeters, dependent on the distance between the spinous process. The midline approach is then fashioned, splitting and separating the muscles and the attachments of the multifeeders from the spinous processes along the lamina to the edge of the facet joint. A burr has been used in this particular position just to tell you how the resection of the facets would be. However, an osteotome is usually preferred so that an ample amount of bone graft is available for the ultimate fusion. So resection of the inferior facet should be completed in toto to allow adequate visualization of the inferior lamina. One has to note that these are 2 L-shaped resections. The superior resection will be the inferior third of the lamina along with the inferior facet, and an inverted L includes the edge of the superior facet and the superior edge of the caudal vertebra. One can resect these edges with a burr very, very freely, since the infolding ligamentum flavum protects the dura and the nerve roots. As a precaution, the ligamentum flavum should be excised after the bony resections are completed. Once hemostasis is achieved, the edge of the facet joint can be resected with upcutting rongers to expose the disc and the shoulder of the traversing root. Adequate resection of the overhang of the medial facet along with the laminofacet junction is important to allow adequate decompression of the traversing root. Coming into the vision is the shoulder of the traversing root. An adequate decompression of the root should be ensured before retracting the root towards the midline. Soft pledgets are used to retract the shoulder of the traversing root, and one pledget is packed into the axilla of the exiting root to protect against inadvertent injury to the exiting root. This allows adequate exposure of the disc in between the soft pledgets. Retraction of the dura towards the midline will allow a midline trajectory of your intradiscal instruments. As you can see here, even with the soft pledgets, an adequate retraction of the neural elements is possible, and the mechanical retraction can be kept to a basic minimum. A thorough discectomy is then performed using sharp cutting instruments to remove the annulus and the cartilaginous end plates. The discectomy can be carried towards the midline by gradual retraction of the dura against the spinous process. The intradiscal shavers can then be inserted sequentially in a midline trajectory angled towards the center of the disc and rotated to scrape off the remnant of the disc as well as the cartilaginous end plate. One should ensure a firm rotation with grating of the cartilaginous end plates as the endpoint of the sizing of the end plate. The discectomy is then completed. The edges of the overhang of the adjacent body is resected to widen the space for the insertion of the cage. The disc is then packed thoroughly with autologous bone graft, either manually or using a funnel. The cage that is sized is then inserted towards the midline and is confirmed with a C-arm picture to be positioned in the anterior third of the vertebral body in the correct depth. This completes the midline procedure.
That's the exiting route, which was decompressed by looking out through the foramen. Here the surgeon is standing on the opposite side. So
the screws are then inserted through separate approaches, as you can see. This allows control of the listhesis in a much better fashion because the approach to the disc is kept separate from the approach to the screws. The screws can be controlled and the reduction maneuvers can be executed separately. The distance between the incisions ensures that there is no edge necrosis, and the midline incision can be kept very small to ensure the placement of the cage.
So, in short, it's one of the same approaches, except that if you're using it for various pathologies, narrow canals, stenotic canals, dysplastic listhesis, you need to have better control on your exiting routes. And here you have the luxury of looking out through the foramen because it's a micro fenestration approach which is looking out, and you can tilt the same retractor inside and look into the canal and do your disc work. So it allows you a better control of the neural elements and offers you a freedom of tackling wider pathologies through a single microfenestration approach. This stops. This doesn't stop.
Thank you, Mir. Any questions from the audience? Can I have one?
Yep.
Sometimes it's an obese patient or a patient with a good musculature. The midline incision sometimes requires a long one. You require a longer incision because to go more lateral to the dura, you require a longer because
this is what I used to feel about a few years back. But really, if you open a tube or if you open a micro retractor, the retractor needs to open only about 1 to 1.5 centimeters. You expose from the midline to the medial edge of your facet. The facet joint can be resected through that.
So you have to go at an angle to the midline.
Yeah. So basically,
so then you have to retract the dura a little bit more.
No, you don't that. You tilt the retractor.
What he's trying to say is it is a physics. If the patient is obese, from the skin up to the lamina, the depth increases and you have to increase the length of the incision. It is physics, nothing else.
No, see,
If you use a tubular retractor, it doesn't matter. For open incision, you have to increase the incision.
this patient was 8 centimeters inside, 8 centimeters, and this patient had an incision of 2 centimeters.
Will you think that a thin patient will have the same incision then?
Yes.
No, it will be a small incision.
No, that is understandable. But
It's a
are we
physics.
discussing size of the incisions, or
No,
are we
what he
discussing the
tells-
complexity?
No, what he is saying is in obese patient, you have to increase the size of the incision.
No.
That is a physics.
No, sir. I don't think so. That is not true. It is not true. Because through a uniportal approach, when you have an anchor on your spinous process, you have a very strong retraction against your muscle and it opens very easily. This is a concept which you have because probably this is a technique that you need to see. When you see it opening, this whole procedure gets over in 40 minutes with not even 100 cc's of blood loss in obese patients. So it's a question of how you execute it. You don't have to take 5 centimeter incisions at all. Never.
No, I know because I've gone through this whole evolution since 2007. This was the first thing that I did before I even started the tubular retractor.
Basically, he is talking about physics, nothing else.
Anyways,
Depth of the lamina from the skin incision.
No, that's fine. But that doesn't mean that your size of the incision goes astronomically high.
Increase in open, in tubular, it doesn't matter.
Well, that's a concept.
That's okay. Thank you very much, Mihir, for a very nice video. Can I call upon Dr. Amit Jala to speak myself? Mihir, your pen drive. Okay, video. Keep the audio also. So, okay, so we are in the OT.
What to do? Just ask Malcolm whether to continue with this or be like.
Should I continue?
You decide what to do.
So after 7 minutes, they can wait for about 7-8 minutes.
No,
Yeah.
We are ready now. Because we had already waited.
PC?
Yes.
PC, just wait for Amit Jala's lecture to finish for about 7 minutes and then start.
Okay.
Just wait. Yeah.
Okay. Continue.
Okay, so thank you, Dr. Malcolm, for inviting me for giving a talk in this World Endoscopic meeting. And I've been talking on tubes and endoscopes for a long time. And there is always a heated debate, or what I would not say a debate, but whenever these talks are there between tube and endoscope, when I go outside, there are a lot of young surgeons who come, what should be used, whether we should use a tube or an endoscope, because they are always confused. So it is always better to give them the right perspective of each and every technique and let them choose what they want to do. Because sometimes it matters on the mentor also, because if their basic training is in endoscopy, they will pick up the endoscope, but they will lack in the tube. And if they have a tube person as a mentor, then they will pick up the tube, but they will not go to the endoscope. And as we all know that as we grow, sometimes we require both the things in our armamentarium. So this is for basically the young fellows to give them what is the right perspective of endoscope versus the tube. So as Mihir told me that he's going to just give the audio with the talk. So this is a recorded talk again. So I'm just playing the recorded talk.
Everybody, whether to use tube or an endoscope. There is always a heated debate in the conference, and I've been seeing and watching and even involved in these debates whether to use tube or an endoscope. These debates are done by the key opinion leaders and masters.
Can you increase the volume?
The young fellows who are watching this debate are always confused because both the masters will show their best results. So in this short presentation, I have tried to give head-to-head comparison between the tube and an endoscope. Now, in 2002, I started with regional microendoscopic discectomy technique, and wherein the endoscope was fitted around the tube and the procedure was done with the help of the endoscope assisted tubular discectomy. The biggest problem here was fogging of the endoscope and the field of vision, which was less because the endoscope would come in the way of the tractor. And you can see the field was bloody compared to what you can see now. And in 2008, I started using tubular discectomy, wherein we stopped using the endoscope and started using the microscope. And the biggest advantage here was you can use the whole diameter of the tube, and with the help of the microscope, you can get a good magnification. So the procedure where you can get a better space of working area, and with the help of the microscope, you can get a good three-dimensional vision, and you can do the same procedure very nicely with the help of the magnification. But in 2016, I started using the full endoscopic technique, and you can see that there was a drastic difference between the vision. You can see the clarity of the vision, and this clarity of the vision, which was absolutely bloodless, which was because of a constant irrigation, and you can get a good magnification by use of the endoscope. And therefore, each and every technique has got their advantage. So what I have tried to do here is give you the head-to-head comparison by point-wise taking each and every point. As far as the vision is concerned, tube gives a good three-dimensional vision because of the microscope, but the field is usually bloody, while compared to that, the endoscope will give 2D vision, but you will have a better and clear field of vision, and therefore the advantage goes to the endoscope. Magnification, if you use the microscope, then you can get a very good magnification with the help of the tube. But the advantage in endoscope is that it's a real-time magnification, because with the help of the endoscope, you can just go as near to the field of vision what you want to look for. So it's a real-time, and therefore the advantage goes to the endoscope in magnification. Handling, definitely compared to the tube, endoscope has got a more learning curve, and the handling, because you have to use both the hands, and the tube has an advantage compared to the endoscope. Reachability, the tube has got less reachability because every time if you want to look at the corners, you will have to want the tube. While in endoscope, you can just move the endoscope, and as such, the endoscope comes with 25 degrees of vision, and therefore you can get a better or a more field of vision compared and reachability compared to the tube. And the advantage goes to the endoscope. The surgical time will decrease as your experience increase. Though I have said that tube has got less surgical time, but I think both are equal, because once you master the technique of an endoscope, the surgical time is definitely going to come down. Learning curve, endoscope has got much more learning curve. There is a steep learning curve in endoscope compared to the tube. Versatility, tube has obvious advantage because it can be used at all the levels of the spine, and you can do all the procedures like only discectomy and decompression and fusions with the help of the tube. Well, endoscope, it's definitely less versatile because more of the decompression procedures can be done best by the endoscope. Anesthesia. Endoscopic procedures can be done under local anesthesia, and in high-risk patients, this is a definite advantage compared to the tube. Outcomes, they are both nearly the same. Complication rates, they are much more. Initially, it is high in endoscope, and the biggest problem is inadequate decompression. So there are no limitations for the tube, but there definitely is a limitation in endoscope because you cannot do the fusion. So advantage goes to the tube. The incision size is definitely much more smaller in endoscope compared to the tube. The equipment cost. If you use the tube with the microscope, the equipment cost will be high. But if you start using with the loops, then the equipment cost will be very low compared to the full endoscopic, where there are a lot of other gadgets which are required, like RF and burr and specialized lasers. And therefore, the whole endoscope system is much more costlier compared to the tube. And if you use Distando or UBE, definitely the cost can come down. So if you use tube or Distando or UBE, the cost is less compared to a full endoscopic system. There are no recurrent costs in tube, but in endoscope, you have to use RF device. There are scope issues, there are instrument breakages, and therefore tube has an advantage in recurrent cost. Portability, yes. If you use a loop with the tube, then it is portable, and endoscope is always a portable. So both are equal in marketing and glamour. Definitely endoscope is much more marketable. There's much more glamour attached to the endoscope compared to the tube. And if you look at the future, both have a future. Technology which is fast advancing, you are getting better fusion related equipments and devices for an endoscope. And therefore I see a future which is there even in an endoscope. So it's an equal compared to what the tube and the endoscope is there. So the take home is both have their own advantage and disadvantages. For decompression, yes, endoscope is better and do the job, but as limitation definitely for the fusion. The tube can be used as a bailout technique if the endoscope fails. So it's better that you should have both the things with you. The last message is you must train for both the technique, check what works best in your hands, what are your skills, and master that technique first. Once you've mastered one technique, you can go for the other technique and never try to do all the procedures through the single technique. Thank you very much.
Yes, Dr. Rohidas.
Last sentence.
Yeah. 100%. We are surgeons and we should know that all the techniques, what are better, you should use that for.
I can do everything with this kind. Even intradural tumors, higher level tumors.
Can you do an anterior approaches with the Destando?
Which approaches? Cervical, anterior cervical, I do.
Abdominal, retroperitoneal.
It's not.
It's a tube.
Correct, but
you cannot.
Listen, these are completely different. Transthoracic, you can use a transthoracic laparoscopic thing.
Yeah, so that's what I'm telling, that you should know each and every. You should not have one technique oriented.
For that, you need a different endoscope. You need a laparoscope, but can be done.
You cannot do 100% work with that.
I can do disc, canal stenosis, thoracic disc, anterior cervical, posterior cervical, and intradural tumor. What else you want? You can do fixation if you want.
Okay, message taken very well.
Yes.
Thank you very much.
Nice to meet you. I came from South Korea, and a very nice city. And you mentioned about the endoscopic technique, but there is different. What I'm doing is bipolar endoscopic spine surgery. Only we cannot do is intradural, extramedullary miss. We cannot do endoscopically, but other things we can do everything, especially in the fusion surgery and cervical lateral mass screw fixation. We can do decompression, everything. And one portal endoscopic surgery and the biportal endoscopic surgery is different, very different.
Absolutely right.
Okay.
Absolutely right.
Yeah. Thank you.
Recurrent cost in UB. There is a recurrent cost in UB. If you are really interested, you have to use this. You cannot use the same this thing RF for second case. So it's definitely a recurring cost. In UB, what happens? It is a single hand technique. There are chances that you will damage the endoscope quite often. That's why the masters, they use a very cheap endoscope. When they are demonstrating, they will use a high end, very good endoscope. So these are the two things you have to take into consideration. It's a recurring cost in UB.
I think I absolutely feel that you should know all the techniques. That's what I feel. You should not stick around with one technique. Because
That's
sometimes
okay. You
have
can
a
have
problem.
all the techniques. The Max More have the instruments for 7 different techniques. You have to have that much of money. You are telling the youngsters how they can
Yeah.
start.
So I think I have started the debate.
But
I started the debate, and this is what always
I-
happens in the meetings.
Okay, in my opinion, I think not. You can do one technique for every cases. It's true, but which technique is more easier for the special disease? For example, the foraminal stenosis. UBE can, but not good, because the approach, the lens, right? The uniportal is more minimally and more easier. It depends. You can do everything, but it depends on which approach proper for which disease. I think it's no need to argument.
It's not a question of argument. We are telling the young people when they want to
So,
start.
so for the young people, if they want to choose out of the 3 technique, what should they do?
Can I mention last one?
What
please?
should they do? I think from all the faculties, I want an answer that for a young person who has just come out of his fellowship from spine and he wants to start a technique, whether he should, because this is a very common question. When I go out, they just ask me, what should I do?
I think you should learn everything.
No. What patient is demanding you? What
No,
patient?
we just take it as a science rather than going to
So
the
I think
patient.
first you should be a
What
good
is
open
patient demanding
surgeon
from you?
to be a
Very
good
important.
minimal access surgeon.
No, after that fellowship of open surgery, they want to come to the
They
minimally
should learn.
invasive.
Of course, see, as evolution goes, when we started 25 years back, I trained as an open surgeon. We moved to microscopy, then to minimal access, and now is the endoscopy time. But I mean, you can't be an extremist of any ideology. It has to be the middle path. You have to do what is good in your hands first. Second is, of course, you have to keep on evolving to adapt to new techniques. What is new today is going to be old tomorrow. But
I think we'll start the surgery.
Yeah. Thank you.
Yeah, but I think you should know everything and then choose what is best in your hand when you're mature.
So that was my take-home message. Thank you.
Now we are starting with, now this is the view you get with the endoscope. It is a 360-degree view. You cannot get with a tube and microscope this view. And for youngsters, they should choose which is, they should look at their pocket when they want to start.
Please, sir.
We have tendency to buy a Mercedes car, but don't spend for the instruments. That is the initial problem.
Hello.
Yes, sir, we can hear you. Please start, sir.
Yeah, Amit, thank you very much.
PC,
for your talk.
can you orient us?
Yeah, just I'm just waiting for that. Are you able to see my outside picture?
Yes, sir, outside,
You have to
inside.
speak loudly.
Okay, so my left
Loud.
hand is going down and up. That is my substantive, and my right hand is the spatula or the pencil retractor. And I am on the this is the superior lamina. This is L5S1 left approach. So this is the L5 lamina, and this is the S1 lamina, and this is the facet, and this is the midline or the spinous process. So this is the cranial, caudal, midline. This is the spinous process, and this is the lateral, right? So left hand is the substantive, right hand is the spatula or the pencil retractor. I am at the spinolaminar junction. This is the spinous process, and this is the lamina. I am at the spinolaminar junction, right? Are you able to see?
Yeah.
Okay. So now the first bite will be at the spinolaminar junction. This is my way to approach. I think a lot of people are do that because this is the area where the dura is little away. So my first bite, I used to use this kerison. Very rarely I use this drill like some of the people. And this is the 45-degree kerison punch for the bone, and 90-degree I use for the soft tissue. Okay. So this is the first bite I take at the spinolaminar junction, and gradually I go laterally. And this is the area where I have to take little bone so that my ligamentum flavum, so this is my ligamentum flavum, this is the yellow ligament, which is now detaching from the cranial lamina. Now I'll go laterally. So the lateral aspect of the lamina. The whole set of the instrument is mobile in my left hand. I can do that in this way, only in the left hand. And I'm not holding the camera here. Both the hand is free. Left hand is only controlling the suction tip, thumb and the index. Other two fingers stabilizing the instrument. So yellow ligament is now detaching gradually from the cranial lamina. This is the area where the ligamentum flavum is attached most cranially.
For the young
So
people, if they have any question during the surgery, they can ask.
The superficial layer of the ligamentum flavum. This is the superficial layer of the ligamentum flavum. At the same time, I am trying to find out the junction of the soft tissue and the inferior lamina. So this is my inferior lamina or the S1 lamina, and this is my superficial layer of the ligamentum flavum. I am removing the superficial layer so that the area where the junction of the soft tissue and bone is clear to me. Now I am trimming the bone from the inferior lamina. As you know, the ligamentum flavum is just attached at the superior border of the inferior lamina, so no need to remove the bone here. Only trimming is enough to detach the ligamentum flavum. So this is the area. I'm just trimming a bit of the bone from the inferior lamina to detach the ligamentum flavum.
To appreciate the endoscope, the instrument, and the suction tube. Everything moves together. There is no blind spot in the surgery. It's a 0-degree endoscopy we are using as an angle scope. That's why very good vision with the 4 mm 0-degree rigid scope.
It's my cranial fatty. I am trying to put at the shoulder of the north root. Let me try. So this is the area where the foramen is there. So north root is entering into the foramen. I have to remove this the SAP, the hypertrophic part of the SAP. That has to be removed to decompress the north root to the foramen. I'm just trimming the medial part of the facet. The medial part of the facet and the SAP. Here is the epidural where you get the bleeding point. See, exactly just across the area you get the bleeder. Till now, there is a beautifully called nice anesthesia. It's very nice was I was waiting, not getting anything. And now she, this is my cervical cancer, this is my cervical cancer, and not good. And this is Dora, and this is the flower. So this is a bit hard, this long years. I don't know. I'll try, yes. So this is the area where the this is there, I will try to access. I put in my not and track protect and not immediately so that I know it's more for my 11 plate. But this is not like open surgery, nothing facial. The orientation, everything. This is 30s. Are you able to appreciate on it?
Yes. Very nice. It's always wonderful to watch you doing this surgery.
You can know.
Yeah.
I think this surgery was for you.
Yeah.
But PC, Amit still feels that his fluid is better than air. PC,
Thank you.
Amit still feels that his fluid is better than air.
See the amount of this coming.
So the controversy that I raised before your surgery is still persistent. Whether fluid is better or the dry is better.
That is a $1 million question. I don't know. I want to enter into that. I'm happy with my surgery.
Don't worry, I'm here to answer each and every question. Don't worry.
I need to learn all the technique, but I am happy with this technique because I can use in the stenosis also, multiple level stenosis also. So I am happy with this.
Sir, next election we should bring you up. Full political reply.
You are doing a good arthroscopy, right?
Yes.
So what is better?
He has tried. He has tried.
So I am going to the. It is only straight. This portion.
You come tomorrow morning and I show you.
He tried UV, but he was not happy.
I'm still able to bend the total set of the instruments, torque it little bit about 20 to 25 degree and removing the disc. Even I am going able to go to the center of the disc by tilting the whole set of the instruments. Right? I think 1 or 2 bites more. I am enough. My normal is totally decompressed after the foramen.
PC.
I have removed a bit of the bone from the SLE with medial aspect. So the lateral column stenosis part also taken care.
PC.
Yes.
Amit wants to ask your orthopedic surgeon.
Yeah.
So why you are not happy with the fluid medium techniques?
Yeah, that is this fluid. I think I have tried with the bipolar, and I went to the master Dr. Son, South Korea, and I purchased, but again stopped because it took little more time and also the cost little more to the patient. This RF around 20,000.
We have one UV set for sale if anybody is interested.
And this is the
And directly from Dr. Son.
See, this is the
Directly from Dr. Son.
I'm using for last I think 10 years. Same bipolar. I think total within 15 years I have changed only once the bipolar. Otherwise, no need to spend the money for the RF. That's why. Otherwise, it's okay.
No, but PC, Malcolm ji,
So,
everything
Vilas,
comes to
are you
money.
interested to show me something more? or it is the end of the surgery?
Thank you so much, sir.
Just show the route how it is free.
1 second. Huh?
You have to put a gel foam, small gel foam there. For the youngsters, everything comes to money only, nothing
Yeah,
else.
this is the route. You can have this impression. 1 second. This is a little bleeder. Can I have this surface a little? Okay. Appreciate the freeness of the nerve root up to the foramen. This is the foramen, and this is the SAP I have removed here, the lateral canal, the medial aspect of the SAP. That was hypertrophied, and that's why the medial canal stenosis.
The advantage of this technique is this is the cheapest system which is available. That's why STAWS people are not advocating it because they don't get money. Straightforward.
So this was a small surgical stop my bleeding. Now see this, and there is a cautery, nothing else.
Thank you. I think we'll start with our talks. We are running late. Can I
Irrigation
just have a
done by
look
the
at this?
normal saline and gentamicin to the disc space. Okay.
Yeah.
Now this is my cranial, caudal, and midline and lateral. Okay. Amit,
Mihir is there.
it is finished.
Mihir is left, I think.
Should I stop?
Thank you. Thank you, sir. Thank you so much.
Dr. PC, you have done an excellent job.
Thank you, sir.
Thank you.
We'll cut off the theater. We'll start with our talks. And before we start with our talks, I'd like to introduce our most esteemed guest, Professor Yum Jinwa. We are pleased and honored to have you with us. He can be rightly called as the doyen or the pioneer of UB endoscopic spine surgery. And I think he picked it up from Dr. Abdul Ghaffar as what he has told us. And I think he has gifted the world a very wonderful procedure. Thank you, sir. Thank you for being with us. We'll start with our next session. And we have one virtual talk from Dr. Xenia Ito. So can we just please connect that immediately? And can I please request Dr. Vishal Kundani, are you there with us? Or I think he's left. Dr. Antav, can you please chair one session for us, please? And can I please request you, Dr. Prompavit, to chair one session with Dr. Antav?
Unilateral. Unilateral laminectomy for bilateral decompression, ULBD, has been performed. We performed 4 endoscopic methods, which have their own merits and demerits. So we would discuss the points of comparison. I would compare 4 endoscopies of MEL, PFEL, PSLD, and UBEL. The 4 methods differ in terms of working space, working length, and skin incision. The last 3 are endoscopic procedures and the continuous water irrigation. 4 surgeries share the same basic operation procedure, step by step. After skin incision, clearance of soft tissue, partial resection of the inferior edge of the cranial lamina, and revelation of the ligamentum flavum. Next, from the caudal lamina, and then from the contralateral and ipsilateral laminas are performed. MEL procedure, step 1, sublaminar approach. Firstly, the outer ligament layer must be sutured, and then the upper lamina must be sufficiently. The lower lamina is relatively easy to detach the ear ligament because of light attachment of ligament to the bone. MEL procedure step 2. The contralateral hypertrophied SAP can be quickly cut by a round chisel, and the lamina can be decompressed using a forceps or a calison. The ipsilateral lamina is also resected with a drill or calison, but trumpet bell-shaped resection is difficult in deep areas. There is a risk of over-resecting the upper and lower facet joints in the narrow upper lumbar level. PFEL procedure, step 1, soft tissue resection. Firstly, the muscle and adipose tissue should be dissected so that interlaminar inner ring is clear. Next, remove and ablate the soft tissue until yellow ligament appears. A percutaneous endoscopy must be entered from more caudal point. Ipsilateral laminar wall can be deemed using mainly 3.5 mm diamond bar. SAP can be dissected by a small calcium. Finally, remove ligament entasis from bone with a curettage. Contralateral side decompression. Contralateral yellow ligament must be detached. After contralateral superficial yellow ligament was detached using a forceps. The deep ligament entasis is cut off from the contralateral lamina with a diamond burr. Especially important, the right superior adherent facet has to be removed in the shape of a trumpet bell. In the unilateral approach, it is slightly difficult to remove the lower part of the upper lamina and the ipsilateral medial wall of the canal. Our hospital developed more caudal another portal reaming method, which was more easy to reaming difficult zone. Cases predominantly with ligamentum flavum thickening and mild facet degenerative hypertrophy are ideal indications for PFEL. This is a time-consuming procedure because few tools are available, and cases with a lot of bone removal are not indications. A stenosis endoscopy with a 9.5 mm outer tube has a 5.5 mm working space for the larger many kinds of instruments to be used freely. The end keratine punch with the biting part of 1 to 5 mm can be used in it. Steel cutting bar, diamond bar, and high-frequency soft tissue ablator with hemostasis can be inserted. First, ablate the fat and the yellow ligament thin as possible with high-frequent radio wave. The deep layer must be kept till the last procedure. Since the yellow ligament at the upper side of the canal is strongly and widely stuck underneath the L4 lamina, we have to remove plenty of the L4 lamina on the base of the spinous process. Then the yellow ligament from underneath the L4 lamina must be removed by a calcium punch. Because the caudal outer and inner ligament layers are not so strongly stuck, they are easily detached. However, never cut the thin capillary membrane to prevent excess bleeding. The ipsilateral lamina wall and the deep yellow ligament are removed using a chisel and a calcium. The contralateral yellow ligament and the lateral recessed bone must be removed using a chisel, drill, and calcium into a trumpet bell shape. Adipose tissue and remaining ligament entasis must be cut. OIL plus lumbar central canal stenosis at L5S1 using PSLD. This was a hyper-obese patient weighing 102 kilograms and required an outer sheath of at least 9 centimeters long as well as a large amount of bone removal, thus making this patient a good candidate for PSLD. OIL is susceptible to dural damage due to slight shaking of the hands, and PSLD is safer than UBEL because the endoscope and the tool can be grasped together with both hands. UBE overall procedure: soft tissue ablation by high-frequency electrode, sublaminar drilling, detaching the yellow ligament by a dissector, resect lamina by a calcium nodule. Circumference lamina drilling, the yellow ligament by a curettage, remove the yellow ligament by forceps. Resect the same side lamina by a curved calcium nodule, retract the root by a curved dissector. Resect contralateral lamina by a calcium. Hemostasis, cut opposite SAP by chisel. Remove bone mass by forceps. the tract route, blood section tube, UBEL for central canal stenosis at L34 and L45, as there are no restrictions on the outer sheaths in UBEL method. Many types of tools can be used, providing greater tool selectability than any other endoscopic technique. 139 cases of MEL, 85 PFEL, 19 PSLD, and 42 UBEL were operated on. Their operated level ratio, male and female ratio, and age average were not significantly different. Perioperative result 1. MEL operation time was the shortest. Next, UBEL, then PSLD was moderate, and PFEL required the longest time. There was a significant difference between them. Perioperative result 2. Amount reading of MEL was significant much than other three endoscopic methods. PFEL tended to be smaller than PSLD. Dural rupture incidence was not significantly different. Clinical outcome 1. Compared with preoperatively, burst of back and buttock pain was significantly improved at each measurement time by all 4 endoscopic surgeries. However, there was no significant difference between 4 groups. Similarly, burst of leg pain and numbness, ODI, and EQ5D also significantly improved at each measurement time by all 4 endoscopic surgeries. However, there was no significant difference between 4 groups. Image analysis 1. Ideally, the resection cut angle of the bilateral superior articular process forms a trumpet bell shape. UBEL resulted in significantly more trumpet bell shaped cuts than the other 2 types of endoscopic laminectomy. Since MEL outer sheath is wide, the approach side cut angle is minus, and it tends to be a reverse trumpet bell shape. In particular, at the upper lumbar levels, where the lamina width is narrow, care should be taken to avoid excessive resection of the facet. PFEL and PSLD had no significant difference. The bone resection area in 3D CT was measured at L34 for each case. The unpaired t-test showed that UBEL produced significantly smaller areas than MEL. Because MEL's outer sheath is 16 mm, but UBEL has no outer sheath. Multifidus muscle fatigue degeneration caused by outer sheath continuous compression may result in lumbar aches and stiffness. The Gauteriel classification has 4 stages in T2 weighted axial image of MRI. In elderly, since many multifidus fat degenerations are already seen at the lower lumbar level, so I evaluated only at L34 with little influence on age. MEL has more muscle damage than the others. Conclusion: operator can use both hands by MEL, and even multi-level surgery can be completed. MEL also provides a wide view for dural knot suture. MEL operation time is the shortest. 3 endoscopies and a continuous water irrigation provide clean, fine views. These long instruments are suitable for obese patients. Especially, UBEL can use any tool available. PFEL operation time is the longest. Postoperative bleeding is moderate in MEL and minimum in PFEL. MEL has several percent of dural rupture, and the others have a few. clinical outcomes has no significant difference between all methods. Bone resection area is narrowest in UBEL and it's wide in MEL. Approach side cut angle is trumpet shape in UBEL, and MEL has a reverse trumpet bell. MEL has mild muscle damage, and the others have little. Summary: MEL has short operation time and can use both hands. MEL has a wide view and facilitates suturing of dural tear. MEL operation time is the shortest, but more bleeding, more bone dissection, and more muscle damage. 3 endoscopies under water irrigation provide clean view and less thermal damage. PFEL and PSLD can easily recognize tissue target. UBEL can easily choose the available tools for the most efficient bone cutting. PFEL is the most minimally invasive and good for thick ligament type. In any of the methods, avoid mistakes and become skillful.
Okay, thank you, Dr. Sanya. This is a video, not the online. Sanya, no. Okay. I know Sanya for a long time. And he the rising star. His father is Mr. Ito. And no, he is a spy man. And what is the comment on the floor? For Dr. Chong, you familiar with the UBE, right?
Let's ask your comment.
Yeah, please, Dr. Chung, please give the comment.
Yes, I think, as you know, all procedures have advantage and disadvantages. So there's no one method to treat every disease, okay? So, and everyone have a different talent. Okay? Some doctors can try UB and microendoscopic discectomy and the one-portal discectomy, maybe different. As for me, I tried 30 years ago, I tried one-portal endoscopic surgery, but I failed. The failure rate was too high. So I visited Arizona and met Dr. Yang, and I learned from technique from Dr. Yang. But my recurrence rate and the surgical failure rate is too high, so I abandoned because I'm not a good talented surgeon. And then I tried to find out other methods. So that's the biportal endoscopic surgery because I'm not a good hand, so I have to use the right hand, left hand simultaneously. So maybe it's dependent upon you. Some young doctors are trying to comment that even if bipolar endoscopic surgery is still difficult, it's not easy. Actually, frankly speaking, even I became a convenient for at least 5 to 10 years. At first, the learning stage, I tear dural tears and also recurrent rate is high. But after 10 years, bipolar endoscopy become my technique. So everyone different, okay? I like red color, I like blue color. So convenient, find your technique. There's no difference. Thank you.
Okay, thank you. Dr. Chung, please.
I have 8 years of experience in biportal endoscopic surgery. So I concentrate on biportal surgery. So I recommend In my case, I recommend is endoscopic surgery for young spine surgeon. Thank you.
Okay, Dr. Wu.
Yeah, so maybe I'm in a way young spine surgeon. Not long ago, I went to South Korea. I think Dr. was my table instructor. Also learned from various uniportal surgeon, Dr. Hugh Song Kiang, Dr. Pompavi as well. So, I mean, in the end, we can't convince anybody to do anything anyway. Okay, so what I like about Dr. Zenya Ito is, and I did try to do the same, is be academic about it. Okay, so if you are not sure what is good in your hands, then do a randomized control trial or a prospective cohort trial. Okay, but one thing I always mention, you know, we do in many meetings say that you need to learn everything, but we all have a finite time in our life. And every patient that we do is an opportunity to be better to the next stage or go back to stage 1 again. So if we want to learn 5 techniques, and then unless you have a huge volume and you don't need to go OPD or clinic and just operate the whole day, otherwise it is an opportunity loss. So I felt that at this point of time, maybe for young surgeons to evaluate what is the trend and what is the available tools at this moment. Some things that we have to understand. One is, you know, like it or not, industry does drive techniques to be a better and greater heights. Okay, but they come with a cost. And any product that has no industry support usually will not last very long. Okay. For example, let's say take away endoscopy, take into olive. The first generation L51 olive retractor, you know, the pin is, we typically pin the internal iliac vein and they bleed. Now they have a table mounted retractor. All these are industry supports. So any technique, you know, do have to have an industry that is supporting and surgeons that are continually improving the technique. Then as a young surgeon, then we have mentors who are continually improving the technique, and then we can follow. If it is a dying art, although it is a good art, then we have to evaluate, is this what we want to invest our future in? So this is a very loaded question that I've thought about when I'm learning, you know, open tubular. I spent time in tubular too in my so-called young career, although I'm not too young also. And then uniportal and now biportal. So in the end, you make your own decision. None of them is right or wrong. And then I think clinically, no one can convince you to do what you want to do. Yes, that's what I have to say. Yeah.
Okay, I would like to ask the last question for the surgeon who performed the UBE. If the patient right side symptom and the left side symptom, do you perform in the same time, same period of time, or which side you prefer?
I use both hand in working photo. I trained I'm a right-handed, typical right-handed surgeon, but I trained the left non-dominant hand for this procedure for a long time. So I use left non-dominant hand skillfully. It is very convenient and easy for working portal with non-dominant hand. We can switch portal and especially for stenosis and interbody fusion and cervical too. And we can extend the field of surgery of biportal surgery. Absolutely, I think it is essential to have use both hand. Thank you.
Thank you, please.
You have something to add?
Unfortunately, Sorry. Unfortunately, I can only use the right hand. He is very good, talented surgeon. So symptomatic side first, same as microsurgery. Patient complains left side, you have to send this left side, right side. Same.
I'm in his camp.
He can do it.
I also do both hands, and I teach all my students. We had a cadaveric workshop on pig spine, and I teach all my students to practice with both hands and switching of scopes. When you're learning, might as well learn that little extra. It takes a little extra persistence, a little practice. Believe me, when I used to use the other hand, using my left hand as a dominant hand and scope in the right hand, I used to practice on the pig spine about 3 hours a day on the right side of the pig.
Dr. Malcolm?
And that helped.
Yeah.
Today, it makes no difference whether I'm on right or left. I don't need to think.
All of the spine surgeons here do not start as scopy surgeons. So you were a scopy surgeon, we went to endoscopy, and that is easier for you. All right?
Cheating.
Yeah.
25 years of cheating.
Yeah. Next, the question is, for example, shoulder surgery was an open surgery at one time, and now most of it is arthroscopic surgery.
Yeah.
But there are procedures where we have to do open surgery. Now, are there any procedure in endoscopy surgery which you do not do because it's too extensive that you have to do open or tubular or what?
If there is a scoliosis correction, I mean degenerative scoliosis correction of 2-3 levels, that's fine by endoscopy. But if it's a major kyphotic or a scoliotic correction, we still not have come up to that mark in endoscopy. Maybe someday, yes, but not today. Not today.
Thank you. So we close up the session and then now we start
The last session of the day.
session of the day. Can I call Dr. Santanu Malik?
Please start your talk, sir.
He will talk about techniques and indications and complications of cervical UB.
He's going to talk on cervical epidural.
Oh,
He's
cervical
one of
epidural.
India's most prominent pain specialists. And he's very much into academics. He is with the MGM group of hospitals, where I was formerly a professor. And I've had the pleasure of teaching him transforaminal. And he teaches me all pain procedures. So it's a symbiotic relationship. But all I can tell you is before he starts his talk is that you guys, young guys, you all need to know many, many pain procedures. You all need to know selective nerve root blocks. You all need to know for transforaminal injections. You all need to know facetal blocks. You all need to know cervical epidural. You need to know everything. Today's spine is a merging field. Many people disagree with me, but there is a lot of overlap, and management of pain is a major, major thing, even in a postoperative patient. Many of my postoperative patients with root dysesthesias, pain in the root, numbness in the root, recovering from a foot drop. I had one patient who was recovering from a foot drop. She had extreme pain, and a root block gave her relief for 3 months. And during that process, her foot completely recovered. I didn't have to even repeat it. So you need to know pain procedures, and they are part and parcel of spine. So it's time we except there was an old concept. Okay, you have a foot drop, you operate. You have a neurological deficit, you operate. No, today you operate pain. You target a source of pain, you target a pathology, operate it. Instability causing back pain, yes, you operate it. Or you treat it with pain. Sometimes fusion itself doesn't give you the answer. You need additional pain procedures. So therefore, the world of pain, the world of neurosurgery, and the world of orthopedic spine surgery, all are merging into one. We need to accept that and move ahead. Go ahead, doctor.
Is on? Okay. So, respected all dignitaries and especially Malcolm sir, my mentor in transforaminal endoscopy. Though I'm an anatomist also. So first of all, I would like to show a small video on dissection of the cervical epidural. This is one of my favorite procedures, more than 15 years. I'm doing these things. You can see the cervical spine. This is first rib. So this is C7. This is T1. C7 and T1. I'm going in between the C7 and T1. 18 gauge needle. Okay. I've just reached. Now use the loss of resistance syringe. So it has gone inside. Okay. Okay. Now we can see the cord. Okay. Now there is no CSF, that's why so much space we can see, but we can see this is the needle tip. Try to put the catheter. This is the thing is happening actually, but you have to know scientifically the technical things, how it is done. Different indications are there. During my anesthesia practice, lots of cervical epidural I have given for high thoracic surgeries, upper limb surgeries, breast surgeries, neck surgeries, combining with epidural, combining with general anesthesia. But nowadays in pain, regularly I am giving for cervical. Many times patients are not ready for cervical surgeries initially for conservative. Better to give, even I myself has taken also cervical epidural for cervical disc herniation pain, but it worked well. So there's a very good support, but you have to know the complications, dural punctures, even for this spontaneous headache, CSF leak. In many patients, I have given this epidural blood patch, this cervical level, because continuous headache, it was not controlled. Then after CT myelo, they have diagnosed some leakages there in the cervical level. So in those cases also, it can be used. So you have to be very, very cautious about this technique. Lots of complications may happen, but if it is properly trained, you can definitely do it. So most important thing, cervical epidural, earlier, lots of people, they have given blind, but nowadays, cervical epidural injection should always be performed under image guidance. Though image guidance doesn't absolutely protect the patients from the complications, but the risk by providing a third-party verifications of various stages of the procedure in objective and quantifiable terms. So it will help you to understand what was the problem. So otherwise, always have to done under image guidance. Let's come to the technical part. So the most important thing when you are doing, many times I used to say anesthetists nowadays learning ventilators, they're learning this laryngoscopy, they're learning USGs, but they are rarely learning fluoroscopy for giving epidurals in OT. For coming to the epidurals, they're all giving blind. So nowadays, every OT, they have CM. So for any cases, if they're continuously puncturing, not to get the space, better to always learn fluoroscopy also, because they can give, they can take the advantage of cervical epidural, high thoracic epidural with a perfect technique. So usually the difference between thoracic and the lumbar, the cervical, the lamina is almost 45-degree coronally angled. So that's why the technique is totally different from the cervical and from the lumbar, thoracic, and the cervical. In the cervical, if we see most of the time in the midline, it is not possible because in the lateral view, the shoulder comes. So we should not go more than C5, 6 level, even should not go more than 6, 7 level. C6, 7, C7, T1 is the best level where you get the maximum space. But here, the technique wise, if you see, if you are giving the midline, so we can see, I don't know whether I get any. Okay, we can see here this picture. This is the lateral view where the lamina line is there, and this is supraarticular process, infraarticular process. But in lateral view, foramen is very, very small. So many times patients are complaining with unilateral pain, disc bulge in one side. In those cases, we are trying to deposit maximum dose on that side. So if you are putting the needle on little lateral side, so then if you see in the lateral view, then you will see it will look like you have already inside the vertebral canal. So that is little the dangerous. So, but actually you are not there. You are in the on the lamina only. So to correct this fallacies, we should see the contralateral oblique view. So that is the most important thing. If we see in a contralateral oblique view, so we can see the silhouette of the lamina. So these are the two most important things. Almost 40-45 degree we have to rotate on the opposite side. I will show the video where the foramen will be maximally opened and the superior articular process in the silhouette of the lamina. I will show the video that will come on the same line. So in that way, once you cross, so you can see these two picture. This is the lateral view and this is the contralateral oblique view. So lateral view, this is the lamina line, posterior lamina line. This is superior articular process, inferior articular process is the foramen. Whereas here in the contralateral oblique, we are getting this silhouette of this lamina oblique. So there is the needle. Once I'm crossing this, and you can see how much foramen has increased. So up to that limit, we can take the CM in the contralateral oblique view. And once we cross this, so that is the safety. You can see the depth. In AP view, you can, I will show you in the videos. In AP view, you can come to the upper part of the lamina. That is the direction. So you don't know the depth. In oblique, contralateral oblique, you can see the depth. This is the lamina, silhouette of the lamina. So once you cross this, then only you are entering into the epidural space through the loss of resistance technique. But this depth is giving you the full confidence that what is the, so if the complication rate automatically will be very, very less because you can see the depth. So you can see here how this they have studied. I'm not going to detail marking. So if you are watching from here, contralateral oblique, if your needle is on this left side, so the patient is getting problem more on the left side. I want to deposit more drugs on the left side. So I'm taking the needle first in AP view at this lamina, and I'm taking the CM, the contralateral oblique. I'm watching from that side, and this will create this silhouette of the lamina that will guide me, and I will just cross the silhouette of the lamina and enter into the epidural space. But if I see from lateral view, it will look like I'm already inside the canal. So that is the fallacy. So now let's see the video, the live demonstration. So this is the epi view. So you can see here, this is the T1. You can see this is the space. So first in epi view, I will try one or two levels below. This is the best thing. The lateral part of the lamina, you start here and come to the upper part of the lamina. Don't go to the epidural space now. And then you go to the contralateral oblique and enter into the epidural space. So this is a local anesthesia needle. This is the needle I'm encroaching upper part of the lamina. Now I'm rotating the CM almost 40-45 degree to see how the silhouette of the lamina will develop here. You'll see there. Now spine will also gone that side. Now we'll see slowly the silhouette of the lamina will appear here. So one level here, one level here. So this is the window through which you are entering into the space. So the Tuhi needle, there is a little bend, and really that also you can use it to change the direction of the needle. So this is almost, you can see how beautifully the silhouette of the lamina has appeared. This is one, this is upper level. So this level, this is the window through which you are entering into the epidural space. Okay, now I will enter into the epidural space. I can see the needle is in the ligamentum fluum. I am not getting the loss of resistance. Now once I entering inside the epidural space, I will get the loss of resistance. Now I'll put the catheter and inject the dye to see whether it is intravascular, intrathecal, subdural. So accordingly, you can see how the dye spread there in contralateral oblique, almost vertically up and down. This is the epi view. So in that way, easily you can see here, you can see these are the roots are coming. Most of the dye is depositing on one side. So So now coming to the precautions. Okay, so if you have any doubt in the needle position, always come back and do it again and check in the contralateral oblique view. If you have any leakage of blood, CSF, you should check by aspiration and sharp sensation. If any time, better to abandon the procedure. Now coming to the differences, how will you differentiate whether the needle is in the subdural, epidural, intrathecal, and vascular. So if it is in the perfect position, so we'll see the dye will go up and down, and you will see the roots are coming out. Then the most important thing is the epidural fats. Epidural fats you will not see anywhere, whether it is subdural, whether it is intrathecal, whether it is vascular. If it is epidural, that is the most important point. You have to always check. You can see the epidural fats there. Now coming to the many times, because these procedures, most of the anesthetists, they are not doing, they are very much scared to do that. Complications rate is so high. So before entering into the epidural space, many times they are getting the false positive, because in between the multifidus and the ligamentum vivum, that minimum amount of fat, that can also give you this loss of resistance. If they're injecting dye, this kind of dye spread will come. So before entering into the epidural space, they should not check with dye. That will affect the vision. Now coming to the vessels, if it is in the vessels, so I will show you the video. So always I used to use, we can see how the blood is coming. Always I used to use 2 or 3 ml syringe. Don't take higher this volume syringe, because when you aspirate smoothly, it will aspirate or inject the dye. Okay, you can see how the back blood with is aspiration. That's why I try to put the catheter first and aspirate with 2 or 3 ml needle, so that aspiration will be very smooth. Now I'll push the dye and I will see how it shows in the fluoroscopy. We can see here, you can see here, look at here, we can see how the dye is coming out through the vessel. There is no spread in the epidural space, and it is vanishing. So this is very important to look under continuous fluoroscopy. So because most of the time they are all the epidural venous plexuses there. So most of the time they are not arteries. So you don't have to abandon the procedure. You can change the needle, and again you confirm with the dye, and you can do the procedures. Now, if it is in the subdural space, first of all, you will not get any fat lobules, and subdural space is there in between the dura and the arachnoid. So there is a very minimal space, but there is a potential space is there. So once you're injecting the dye, you can see with this pressure, the space is opening. If you stop the pressure, space is not opening. So this is like a rectal. You can see here, once you again inject the dye, it will again open the space. So in that way, you can find out there's no need to abandon the procedure. You can aspirate the dye, and then you can change the needle positioning, and you can do the procedure, and you will not get any nerve roots there, because it's in the subdural space. You will not get any fat. Okay. Now coming to the, that is the look, how it is looking. Now, if it is in the subarachnoid space, so then we'll see, first of all, we'll not get any fat lobules. But here you will see even if you stop the injecting dye, it will immediate spread everywhere, because it is in the CSF, and you can see the roots also. So in that way, you can differentiate. Before injecting the medicine, you should always confirm, and then you should inject the drug. So take home message from my more than 15 years experience of cervical epidural: it should not be done through blind techniques or in sitting position. It is safe. It can be done under, if it is done under image guidance with proper training. Better not to use particular steroid and high concentration of local anesthetics. Resuscitation kit, IV line is always should be there. Always inject the medicine after dye spread, and continuous under continuous fluoroscopy, and it is effective. Many patients who are suffering with cervical radicular pain. So I am running regular monthly workshop in my medical college. So taking only 10 delegates, so that everyone can repeatedly practice. So if you want to join, you can join. Thank you.
Thank you, Dr. Santanu. In your lecture, you have mentioned something about complications, which I think you have not said much about it.
Yeah, that is the most important thing in cervical epidural. Yes, sir. Yeah. One is your post-dural puncture headache. Very, very common. Even it is common in lumbar spinal epidural also. But in cervical epidural, sometimes the space is so less, needle may puncture, but that doesn't mean it will injure the cord. So if the experienced hand is there, so they can abandon the procedure. But patient should be taken care for 2-3 days and lying down positions with all medications. So usually it heals. Any questions, sir?
How do you know that, like, for example, when you give a lumbar epidural, if he has a, say, slip disc PID, patient always gets that radicular pain. Do the patients also get the same radicular pain in cervical spine?
Radicular pain during giving injection?
Yes.
If you are touching the nerve, that time they can get.
No, they say the radicular pain is increased because of the pressure of the injection.
So that's why the amount of the
Volume.
drug is very, very important. Even for lumbar epidural, we are not giving interlaminar epidural. Nowadays, we can see the MRI, we can see which disc is affected. We are giving transforaminal epidural. But in cervical, transforaminal epidural, usually it is banned because of the injury of the vertebral artery. So nowadays, interlaminar epidural is much more safer. So after putting the needle, first what I choose, I first put the catheter. This catheter is very much blunt. So once a catheter is going inside, the chance of needle prick to the cord or root is very, very minimal. So in that way, I can avoid, and drug should be injected very slow because already the space is less.
Thank you very much.
How long does the effect last?
It varies. Truly speaking, I have taken almost, I had a C5-6 disc during my one tour. I have lifted heavy weight. Then the disc was very much big. I thought I had to go for surgery. I have to go for surgery, but I thought, when I am giving cervical epidural to everybody, why I should not take this? So then Lakshmi Vyas madam, she has given me the cervical epidural. So I have taken rest with proper exercise. Fortunately, almost 8 years gone. So what I feel, whether it is injection, whether it is surgery, that is not the ultimate treatment. Treatment is patient's lifestyle change. If you can change the patient's lifestyle, your treatment lasts actually. Otherwise, why surgeries are getting failed? Because patients thinks it is like an appendectomy, it is like this other surgery. Spine is such a complicated area, you cannot satisfy the patients. So you have to simultaneously change the patient's lifestyle to last your treatment.
Thank you, Dr. Santanu.
Thank
Give
you,
him a
sir.
big hand.
Thank you.
Dr. Zope.
Dr. Nilesh Chope is going to talk on cervical UB.
Hello, good evening, everyone. Master Dr. Nilesh. Thank you, Dr. Malcolm, for providing me opportunity to present about cervical UB. I have done few cases about cervical UB, I would like to share my experience. First, cervical UB procedure follows strict patient selection criteria. This should be paracentral or foraminal. No central disc can be assessed with cervical UB. There are relative contraindication, multiple disc herniation, calcified disc herniation, or osteophyte. Sometimes some trained surgeon can remove osteophyte through UVA approach, or sometimes they flatten the osteophyte with hammer. There are absolute contraindication like instability, central disc herniation. This problem cannot be addressed with cervical UVA. In fact, instability can increase after doing cervical UVA. Pre-surgery evaluation is necessary, like clinical examination, X-ray cervical spine flexion extension to demonstrate instability. MRI spine is necessary. CT scan is also very necessary to know the nature of herniation, because most of the time patient conceal the history about his symptoms, and the disc is already calcified. When you go inside, you are unable to remove anything. Now coming to surgical part, general anesthesia, prone position, neck should be in flexion, shoulder retracted downward, head up slightly. And very important is that the beginner always operate from left side because their right hand is dominant. But those who are master, they can operate a right side herniation also with help of their left hand. Skin marking in prone position, mark the midline, medial border of facet joint, and mark the disc space. Also in lateral position, you see whether the working portal and your scopy portal are properly converging at your V junction area. Dr. Malcolm once told me that there should be at least 2.5 centimeter distance on the skin between those two portals, so that there should not be any triangulation issue. Surgical step, land on cranial lamina, strip the muscle. Here the technology is very important. You should have very good RF cautery. You should have diamond burr, side protected round diamond burr, very sharp 1 millimeter, 2 millimeter Carrison punch. After stripping the muscle from the lower part of cranial lamina and upper part of caudal lamina and some part of medial part of facet joint, you identify the V junction and burr the bone. After burring the bone, cut the ligamentum flavum, you can see the nerve root. Discectomy, most of the time the nerve roots are swollen. There is lot of epidural vessel. There are hook like cautery probe. With that probe, you can lift the epidural vessel and coagulate them. After coagulating vessels, just use small ball tip hook to scoop out the disc and remove the disc material. Limitation of this procedure: calcified disc, osteophyte can't be removed, central disc can't be removed. Advantage: minimal soft tissue dissection, no post-surgery pain, preserve dynamic posterior stabilizer paraspinal muscle, minimal risk of infection, fast recovery. Thank you.
Thank you very much, Nilesh.
You have a video? No.
Sorry.
Do you have a video?
No.
Thank you.
What are the complications you faced in this scenario?
Yeah. Complication first, when you dissect the paraspinal muscle, it bleed like hell. When in couple of first cases, you see that there might be some injury, you get scared, you repeatedly check under Siam. Another very important that you tend to miss the level because the area is very small. Easily you can sleep at upper or lower level. So that should be very properly check under Siam every time. And sometimes some patient bleed, so post-op drain can be good.
Thank you. Thank you very much.
Welcome.
Can I call upon the next speaker, Dr. Shaishav Shah? He will talk to us in UB, TLLF, the way I do it. Yes, Dr. Shaishav.
Yes. Good evening, everyone. I am Dr. Shaishav Shah. Yeah. Yeah, I'm Dr. Shaishav Shah. I'm the owner of Endospine Clinic. I'm attached to a government hospital and a private hospital, Shupecha Hospital. I'll be talking about a UBE leaf, how I do it. So that there are many ways, as we've been seeing since morning, many ways to fuse to have an interbody fusion. I'll be talking about a T leaf, rather midway between a T leaf and a P leaf. So I'll directly jump onto the steps, T leaf steps. It is not much different from tubular T leaf, but the steps, it's a advanced, I'll say an advanced thing to tubular T leaf. Initial marking, entry points, making of the portals, laminotomy, bilateral decompression, ipsilateral fascicectomy. I sometimes do bilateral fascicectomy, disc space preparation, cage insertion, and MIS fixation. The steps are almost similar, just a few steps in the beginning that are different. So I'll come to the initial marking. Here on an X-ray AP view, we generally mark the midline, the lateral pedicular line, and the tip of the transverse process. This is on the left side. This is on the left side of the patient. This is on the right side of the patient. And midline, lateral pedicular line, and the tip of the transverse process. And the incisions are generally the lower incision. The working portal is generally towards the disc space. I mean, a true AP, generally towards the disc space, because we need to insert the cage. So the direction of the portal should be parallel to the disc space, and the upper one is generally 1 inch from the lower portal. And this is the docking point. And this is on the lateral side, lateral view. So I'm starting from the right side. I generally stand on the left side and do the right part. I'll do a right-sided job, do a laminotomy, facetectomy, and then I'll shift the portals to the left side and do the same thing and insert the cage. So this is the making of the portals. This is for the left-sided job. I've already done the right-side job. I generally use these plastic cannulas for my portals. This is the dilation, which is a little bit different from the UB decompression what we do. I generally dilate it till the last dilator in this thing, because we need to do a facetectomy and we need to retrieve the facet. And the facial incision, if it is small, then I think we generally struggle in removing the facet. So this is the video. I'll just jump off the. Okay, skip. So this is I'm doing right side laminotomy. So I generally do. This is a long video. I wanted to skip few parts, but I'm not able to do that. Right-sided spinal laminar junction. I'll do burring. Then I just do initial burring to make the plane. Then use Kerrison punches to have appropriate proper bone grafts. Then a facetectomy in IAP, if need be SAP then, and then switching the sides, doing ipsilateral facetectomy. I think this is a very long video. I'll just skip it. I wanted to skip the part, but I'm not able to do here. I hope you're having the orientation. This is the orientation of the video, and this is the head end. This is the toe end. This is the lateral aspect as I'm doing right side job. This is the medial aspect. So I'm doing a laminotomy. This is a very wrong video, I think. I just skipped the part. No, this is not happening here. I want to skip few minutes. Yeah. So this is the end plate preparation. I'm using a metal cannula here. This is the end plate preparation, what we see inside the disc. So after stopping the fluid, you can see a good blood punctate bleeding. Sorry. To prepare the end plates, we generally use initially to have a good annulotomy, because to get inside the disc space, we need to have a good window. So a proper annulotomy, then the proper shavers which we use, and then the pen field, curettes and pen field. So this is the patient, a 40-year-old female, L4, L5 listhesis. These are the intraoperative images. The shaver, the cage. I generally insert the cage first, then the fixation. This is a 6-month follow-up. You can see good left-sided fusion at 6 months. We generally get good graft because of bilateral facetectomy. The graft leakage is not an issue. And this is one more case wherein I think bilateral facetectomy is more good a job, because we are quite skeptical for contralateral root pain when the disc space is such collapsed. So I did bilateral facetectomy in this case. This is the no degenerative. This is degenerative. Long-standing back pain, leg pain. And this is the literature support for UBE TLIF. Thank you.
Thank you very much, doctor, for presenting your experience. What were the difficulties you came across while doing this?
Generally, I think time is a major concern for bilateral facetectomy. I had 30 more minutes to be spent on the contralateral side before inserting the cage. But I think bilateral facetectomy gives a couple of more advantages, as in I can get a bit more lordosis. I'm not worried about contralateral root pain. I think bilateral facetectomy in selective patient cases, but yes, I'm doing it. It may take some 30 more minutes.
Any questions from the floor? Thank you very much.
Thank you.
Can I call upon the last speaker for the session? Dr. Is this the last speaker?
Yes.
Yeah.
He is also the chairman-elect of our foundation, and post this conference, he is going to be the chairman of Endoscopic Spine Foundation India. Young shoulders with a lot of responsibility.
So let's give him a big hand.
But I will not waste too much time of all of you. Again, thank you for Dr. Malcolm and our whole team to organize such a beautiful conference on all the aspect of endoscopic spine surgery. So today we have all day we have debated whether this approach is good, what should we do, what we should do. But in this lecture, I have tried to channelize the particular approach for particular pathology. So that's why I called pathology oriented approach in spine endoscopy. So your pathology, you should know, or you should well versed with all kind of approach. It is not that difficult to learn all kind of, I think transforaminal endoscopy, almost all people know very well. Interlaminar endoscopy, L5S1, or stenoscopy right now, and UBE is a newer technique, and interlaminar stenoscopy is a newer technique. So all kind of approach you can combine which you have practiced, then you can give maximum result. Like when we debated UB for right-sided pathology, how to deal. So many people are not lucky who have bidextrous, both can use hand they can use. So when right-handed people, it is little difficult to treat with a right-handed right-sided pathology. So for that kind of pathology, interlaminar approach is again monopodal approach is good, and all kind of disc. So transfemoral approach is least invasive approach. So in era of rapidly evolving medical technology, in this era, it is very pertinent to develop, because in general surgery we have almost majority of cases they are dealing with laparoscopy. Unless laparoscopy is contraindicated, they do open surgery. Same thing will happen with endoscopy. We have different approaches for degenerative and traumatic spine, but again there is no consensus for a single approach for all kind of pathology. Which approach you use, or you use one approach for all kind of pathology. So in this presentation, I'm trying to analyze which approach is best for which kind of pathology. Again, when you start your practice, it's big challenge, because initial practice we don't have that much resources to buy a scope and all these things. So it is challenging to establish yourself as endospine surgeon. At that time, beginning of practice, anatomical orientation of pathology, it's MRI, CT, and X-ray correlation, instability, whether disc is calcified, all these things we have to take into account, because one wrong surgery will give you bad credit in the society, and your practice will take some time to establish. And particular case selection is very important for each and every kind for beginning. Proper optics and instrument, yes, this is most important thing. We have compromise in optics and instrument, and then we just blame the surgery, this technique is not good. No, when you start your practice, invest little more and buy best scope and instruments. So, and second is high level of motivation. Initial 3-4 case or 10-15 case, if you are not able to complete that case, you just need to convert it open surgery. It's okay, don't hesitate. Try next more, and finally you will succeed. So selection of approach. This is rough. It is not compulsory. This approach is this. For me, particularly because I'm doing endoscopic surgery since 2015. So for me now, I can conclude. For me, transforaminal approach and its modification, like transpedicular approach, suprapedicular approach, or this above downward migration approach, all approach is suited for L4-5 disc and above till D12-L1. Again, thoracic till D7 we can use transforaminal endoscopy. Interlaminar approach I specifically reserve for L5S1 with small scope. Transforaminal scope I use for L5S1 because here we just need to split the ligamentum flavum, and we just see the lateral margin of traversing nerve root. We can just insert our cannula, working cannula, and we just rotate, and we can easily remove the disc. So L5S1 interlaminar window is almost 36 mm. So we have advantage. Not most of the 99% cases we don't need to remove any bone. UBE or monoportal lumbar canal stenosis for lateral and central canal. So UBE is particularly more useful for central canal stenosis, but lateral recess stenosis are also monoportal are equally good. Again, foraminal, extraforaminal. For me, foraminal and extraforaminal, I use transforaminal approach, and this modification of transforaminal approach. And many people, UBE is also or monoportal also convenient. And fusion in symptomatic instability, we reserve fusion for symptomatic instability. Again, MIS TILI for endofusion, whichever you are convenient. But when you are doing fusion, MIS or endo, they don't add too much if you are achieving good decompression. Cervical disc, yes, if it is central paracentral, anterior approach is very good. And we nowadays with stenoscopy you can even fuse anteriorly also. Foraminal disc and paracentral disc, it is again posterior uniportal approach is very good. Stenosis, people tried UBE and uniportal approach, stenoscopy approach. But for me, if cervical spine, if I can approach anteriorly, especially, so anterior approach I reserve most of commonly. Transforaminal, again thoracic disc till below D7 you can use. Stenosis and thoracic spine, UBE is better than monoportal because you have good freedom, because many time calcification, all these things, UBE will better. So again, we have to see the two route, whatever interlaminar window L45 or L5S1 is, we have to decide before surgery whether you want to decompress exiting nerve root or traversing nerve root. So exiting and exiting nerve root where if disc is far lateral, foraminal or superior migrated, then you need to trace the exiting nerve root. If disc is paracentral, central or inferior migrate, then you need to traverse, you need to trace the traversing nerve root and adequately decompress that root. Again, now starting with the transforaminal approach, you can see from interlaminar window how we target the disc. Again, I'm not going too detail in this approach, inside out technique and outside in technique. In inside out, you first go inside the disc, then maneuver cannula according to location of herniation. In outside in, you directly land to the epidural space and you remove the fragment and target the fragment. Outside in approach, little mature approach, because many times lots of bleeding and there is chances of damage the nerve root is there. But inside is little safe, and beginner it's very easy. So this is the one case, 64-year-old male with low back pain and right leg pain. You can see huge disc central with right paracentral propagation. Again, use the CT scan. It's no instability on dynamic X-ray, mild retro, but stable retro. So we marked from our trajectory is around 10 centimeter from the midline. Half and half view. You can see epidural space. Sometimes we use the side firing laser, but nowadays with good articulating instrument, we don't need. This is an old video, just a main introduction video. So that's why I include in this lecture. You can see nice PLL and annular tear. This herniation is going into the epidural space. Initially, we used indigo carmine dye, but nowadays, and it's not freely available in India. So nowadays we don't use that dye. But initially, yes, to look at the fragment is very good. Yeah, this curved forceps bendable grasper has made life little easy for migrated herniation, especially, and central disc herniation. You can see final decompression, very good tickle sac. Again, extra foraminal here, only difference is you go towards more midline, around 8 to 10 centimeter from the midline. And transforaminal, you target go below the facet. Here you can go vertically, more of vertically rather than usual transforaminal approach. You can see here. You target here, you target the exiting nerve root. You need to trace the exiting nerve root, completely decompress the exiting nerve root. So this is axilla, nerve root, dura. So again, is a 69-year-old female with low back pain, right leg radiculopathy, 4-week onset, no significant past history. You can see some discal kind of cyst on right side, foraminal, extra foraminal area. No instability on dynamic view. So we plan the transforaminal endoscopy amongst other plan. You can see. So here is ligamentum flavum is exiting nerve root. Yeah, this fragment, you can see the gush of blood, some cyst kind, cystic material, so it come out. careful coagulation of remaining cyst wall and complete decompression of exiting nerve root. You can see post-op MRI, very well removed cyst. So second is interlaminar approach for alpha S1. So any kind of alpha S1 pathology, interlaminar approach is, I think, good because it's less traumatic than what we do UB and transforaminal. Transforaminal is many times highly accessed and larger alpha S1 facet. So many times we went anteriorly and we cannot do adequate decompression unless we remove the bone. Here, without removing bone, you can remove the disc herniation. Again, he's a 34-year-old male with severe low back pain, bilateral leg pain. Right is more than left, with right partial foot drop since 2 weeks. Bowel bladder involvement. He's not able to control his urine. Walking distance is less than 2 minutes. Standing time is less than 20 seconds. You can see MRI. There is huge disc herniation. You can appreciate. Very big on axial view. Almost it covered epidural space entire. But he has large window alpha S1, so we choose interlaminar approach. So we almost remove 4 to 5 fragment. And this we can do with transforaminal scope. So your incision is not large and interlaminar window is not that big. So this final picture of decompression. And this I do usually under sensory epidural. We don't use any GA or any kind of anesthesia. We just put epidural catheter. We use very minute dose of sensorcaine, so patient can move a limb during the surgery also. Huge fragment. This catheter. You can see post-op MRI only just we split it only part of flavum. You can see here, and we remove the entire herniation completely. Now third approach biportal. So again, see 64-year-old lady with severe right leg pain since 2 months. Walking distance is less than 5 minutes. Standing time is less than 2 minutes. Not able to sleep due to pain. Severe pain, bilateral lower limb numbness. No bowel bladder complaint. No motor weakness. Again, it's some kind of degenerative scoliosis, but her main symptom is radicular pain. No, not much back pain. So you can see L4-5 severe stenosis and L5-S1 extraforaminal herniation. So here we combine two approach. First we did L4-5 UB to decompress L4-5 stenosis. This is a contralateral root decompression. Ipsilateral. So both root are completely free. And we, sorry, I don't have transforaminal video, but this is the final picture. UB, both incision, this is extraforaminal incision. And this is immediately after surgery. On table, patient is still in a prone position. So modification of endoscopic approach. So whenever the location of herniation is there, you have to modify yourself. Transpedicular, when there is a high down migrated disc and disc is lateral to the traversing nerve root, we can just drill the pedicle and we can remove the fragment. Suprapedicular approach, there is not very high down migrated, but migrated disc is up to the pedicle level. We can just drill the superior lateral inferior part of superior pedicle part, superior pedicle and superior articular process, SAP. Transiliac approach, again in transforaminal, sometime very high down migrate disc, we just put the monoportal laminotomy approach. We only just drill the bone where the herniation lies, and UB in IL paraspinal approach. So conclusion, again, there is learning curve, but you have to try and always listen to your master, because they have gone through all this kind of experiences. Because when they started, there is not too much industrial support, so not too much endoscopic equipment or instrument and quality of optics available. So they have gone through all kind of complication, and they have made themselves pioneer in that field. So their experiences will shorten your learning curve. Again, never give up, and all the best. Again, if you have a chance to become to change yourself and become endoscopic spine surgeon, because I think now next 5 to 10 years is most of the people will move to endoscopic spine surgery, like what we do in general surgery. Most of people are moving to a laparoscopic surgery. Thank you.
Thank you very much,
Dr.
Bhupesh.
for
Wonderful
such a
talk.
wonderful lecture, and always learn from the masters. So you are an upcoming master now.
We are
The
not,
youngsters
sir.
will follow
We
you.
are
Bhupesh,
still in learning phase. Yeah.
can you show one image of an up migrated disc?
Yeah.
Just one image. I'm going to extend your session by just 5 more minutes, because I want one opinion from everybody. Just 5 more minutes. Dr. Yumjuna, I'm going to start with you. If you have an up migrated, highly up migrated disc.
So she's 42-year-old lady with severe right leg pain, sorry, on wheelchair due to severe pain. We have given all kind of analgesic, but no more, not improvement, not much improvement. I have given SNRB 6 days back, but only 3 or 4 days pain relief. Again, pain started. Again, she came back on wheelchair. So no motor weakness, no ball bladder involvement. This is her images.
What would you do?
Really challenging case, but I'm right-handed person. But in this case, I'm standing to the left side, and I'm right-handed person, and the laminectomy, and I put a curved Carison plunger, small or big one, about like this. Okay, we can push the tail, we can catch the tail, and we can remove easily. I don't recommend in this case. Even if I'm a right-handed person, I don't recommend the right side approach. I recommend the left side.
So UB contralateral.
Okay. Dr. Chung, you. Any other opinion? Okay.
I'm Dr. Jong in
So
South
we have started
Korea.
our debate, the last session.
This case is so easy. Right, I am standing on the right side of the patient. I grip the left hand or a digital portal and the working portal with the left hand, and the small, two small phlebectomy, and I use both long probe and short probe. Long probe is 10 millimeter. Short probe is 3 millimeter. And so over the migration, we remove the lower margin of the foramina, more remove the bone, and we probe the shoulder portion of the root, probing. And I have never been unable to get rid of migrated disc.
Sir, any complication or any difficulty you face during this up migrated disc with UB, bleeding or any kind of difficulty you face?
Maybe
because it's an axilla.
The surgery takes 20 to 30 minutes.
Okay.
Okay, thank you. Dan, your opinion.
I would do a right-sided L5S1 interlaminar approach, uniportal, and use a ball hook to snare that thing.
Thank you. Okay.
Hayati, you.
Is it a chronic case? Generally, do you know the upgraded disc can be fragmented?
Yeah.
So I stay in the right side if I choose the UB technique. Then maybe a little bit more laminotomy, limited, and a limited flavectomy. Then I can remove it some special forceps. But sometimes to control of it, I'm changing the endoscopy 0 to 30 degree.
30 degree. Okay. Dr. Peng.
Dr. Peng, your opinion.
I'm a both type of surgeon, but I would do uniportal in this case. I think I would preserve the flavor. I'm even sometimes just use a stenosis scope, drill a hole, and then put a transforaminal scope, translaminar approach. Yeah.
Dr. Amit Thapa.
Well, in this case, I will prefer the Destando system for one simple reason, because this is going sublamina and there are chronic adhesions, so bimanual manipulation will be far more easy.
Now I'll ask myself what I would do.
Yeah. Sir, before that, anybody have any different opinion than this? Anybody wants to do transforaminal? Anybody wants to attempt transforaminal here?
Some people might like to do a laminotomy.
Okay.
Of the fourth vertebra lamina and do
translaminar approach. Yeah. Transforaminal. Okay.
I would love to do a transforaminal.
Okay.
Because I feel that an up migrated disc, you place your cannula just in the foramen, turn it towards the exiting root, go just below the root, put in a hook and just sweep it out.
Only reason here I don't like transforaminal because of alpha S1 and your direction is above downward.
That's
so many
okay.
time if you not able to reach that fragment, so you are not able to confirm whether you have did complete discectomy or not. That's the only reason.
Fair enough. You can have a retained fragment. If it's a sequestered fragment, you're never sure. But if you ask me for my personal opinion, I would love a transforaminal. But
yes,
it's a challenge.
Kiran, you want to say something?
Female, that iliac crest will be at the level of L5, not higher than up to L4. As she is female, you will get the steep entry at the foramen level.
Many times these kind of cases have adhesions.
Yeah.
And to put a scoop, and is it that easy?
Yeah, it's very easy under local anesthesia.
Okay.
Yes, you can use bipolar, you can use hook, you can use bendable, even forceps. Everything are available and very easy, that you cannot have any kind of not more than 10 ml of blood loss and no muscle or no bone cutting.
I think I'll end this debate by only saying one way.
Okay.
We are all spine surgeons. We all do spine surgery. And there are many ways to skin a cat, as long as you relieve the patient of his problem. They're all going to be personal choices. And like Bhupesh told you, please learn everything there is in endoscopy. Expand your visions, expand your horizons. That is the main take-home message of this debate. Thank you very much. Have a wonderful day today.
Let me show you the end of this images. This is what I did.
See, this is exactly what he did.
Interlaminar, and you can see the radio frequency probe. We till reach the end of herniation up to mid pedicle level. So this is a post of MRI.
Thank you. Thank you very much.
ये बंद किया,
ये बंद करूं?
हाँ हाँ और ये
निकल दो, ये कैप्चर कार्ड निकल दो, हो गया पूरा।
ये वो क्या करेगा, हमको क्या मालूम।
क्लोज कर दो, इधर ही क्लोज।
ये उसको ही करने दो ना।
लीव करेंगे।
एंड एंड यहाँ है ना, ये एंड एंड।
माइक देना।